You can start now.
Good afternoon, everyone. I'm Dr. Kendrick Shi, and together with Dr. Akshay, we'll be moderating today's session. So to begin with, I'd like to invite our day's chair, Dr. Caroline Chi, to give her welcoming remarks. Dr. Caroline Chi is currently a senior consultant at the NUH Singapore, and she is also the treasurer of our APOTS Society. So Dr. Chi, please.
Thank you very much, Kendrick. Good afternoon or good morning, depending on where you are in the world, to all the delegates of the second day of the 5th APOTS virtual conference. Thank you very much for joining us today. Ophthalmic trauma is such an important cause of visual loss and loss of human potential, and yet tertiary proficiency is often insufficient due to a lack of formal expertise and training in this area, and the lack of experience in centers that do not have a high volume of cases. The Asia Pacific Ophthalmic Trauma Society was formed by Professor Natarajan 8 years ago to fill in this gap, to proliferate education, research, advocacy, and prevention of blindness initiatives in this area. Thanks to the phenomenal efforts of Professor Natarajan, Professor Azad from India, Associate Professor Rupesh Agarwal, Dr. Ganga Sundar from Singapore, and the enormous contributions from colleagues like Dr. Annette Hoskin from Australia and so many others, we are on the way to fulfilling these aims. Today is the second day of the webinar. Yesterday, we had more than 1,500 delegates joining us, vindicating the use of this platform as a means to reach out to colleagues throughout the world. We were given a master class in ophthalmic trauma and learned many very practical tips as well as cutting-edge practices in the management of trauma in all the subspecialties of ophthalmology, except for the retina, which is in today's program. Today, we'll also be treated to the absolutely indispensable role of allied health professionals in ophthalmic trauma, to global perspectives in ophthalmic trauma, and the exciting trauma quiz. all of you tuning in, the delegates, make this conference a great success and make us a community committed to preventing blindness from trauma. A big thank you to take away from the meeting and the community.
Thank you, Carolyn, for a wonderful start, and thanks to talk about your voice is breaking, right? Ganga, you can.
Okay, so thank you, Dr. Chi, for the kind remarks. So we'll begin our first session. So before I pass the microphone to Dr. Annette Hoskins, I'd just like to mention, so we need to keep the time. So for all speakers, 1 minute before your presentation is about to end, one of our moderators will let you know. So please wrap up your presentation once you're informed. We'll leave all questions to the end of the session. And please, for all the audience members, you can fill in your questions in the chat box and we will address them during the panel discussion. So for the first session, it will be Allied Health, and I'd like to introduce Dr. Annette Hoskins to lead the session. Thank you, Dr. Hoskins.
Thank you very much, Kendrick, for the introduction, and Caroline for your welcome note. I'm really delighted to be able to be chairing this session along with my co-chairs, Daniel from Bohan from Singapore and Chawan from India. We have a great lineup of speakers. First of all, we're going to have AJ Kumar speaking about refracting post-traumatic eyes. He's based in Singapore, and without any further ado, I'll pass over to AJ to give his presentation. Thank you.
Okay, good evening, everyone. In this presentation, I'm going to share how optometrists can play a significant role in post-ocular trauma management. As we all know, in clinical practice, autorefractor is the first choice for most of the clinicians because it provides the good baseline to start the subjective refraction, and it does help in the time management. But retinoscope having its own advantage in the post-trauma management because it does not give only approximate refractive error, more importantly provides qualitative evaluation of retinoscopy reflex. For example, irregular reflex, it will suggest optical irregularities. Dark patch give you the idea of cataract. If having seizing reflex, it will give you thoughts of keratoconus. Or in case of nystagmus, where the amplitude of nystagmus going to increase in primary position, it's difficult to perform the autoref. So again, retinoscope is the first choice over here. So we can see how useful retinoscope can be in post-refracting management. As we know from the literature, that trauma is associated with the refractive error, and most of the time it's myopic shift. And this myopic shift could be because of ciliary spasm, uveal effusion, anterior displacement of the lens iris diaphragm, or increase in anterior-posterior thickness of the lens. If transient myopia is due to the ciliary spasm, we should perform cycloplegic refraction. If myopic reverses, it confirms it is because of the ciliary spasm. So we'll move. I have to share two cases over here. As my first case is 11-year-old female, and it has sudden loss of vision in the right eye due to a spot injury, and she don't have any systemic and medical condition. On clinical examination, the right eye was counting finger, and it won't improve with the pinhole, but the left eye was quite normal. On slit lamp findings, corneal aberration was there. In AC, there was a grade 1 cells and flare, but there was no RAPD. On fundusoscopy, there was a hazy view, but left eye was normal. On her second visit, after a month, on slit lamp finding, we saw a dense cataract, and we advised for the cataract surgery, and we informed her poor visual prognosis because of the hazy view of the retina, and sent for following tests, especially we thought doing the VEP in order to assess visual potential of the post-op. But when patient came to the refraction room, we tried to do the retinoscope. There was no central glow, but there was a peripheral glow. So we did the retinoscopy over here and able to achieve 6/18 vision from the counting finger 1 minute. So this shows how significant improvement was there with the peripheral retinoscopy. So in case of the post-trauma cases, we can see the peripheral retinoscopy has a significant role to eliminate most of the non-essential tests, and it does reduce anxiety from parents as well as the patient. I'm moving to my new second case. The 49-year-old female complained of photophobia and tearing for last 4 years, and she does have difficulty while reading. And she was having the previous history of foreign body removal and diagnosed with the dry eye syndrome and geared with the tear supplement. However, there is no improvement in her symptoms. On her clinical examination, the distance visual acuity was quite close to the normal, but she does have reduced near vision. On slit lamp finding, we saw the few superficial punctate keratitis and faint scar was there. Others are within normal limit. So because she was having the complaint of the near vision, so we did subjective refraction and we are able to achieve N5 from the N8. And we can see this is because of her current glasses was under prescribed. And she does have the dry eye symptoms. So we did the Surma test and it was 10 mm from the both eyes. So looks is the borderline case. So we have advised to continue her previously prescribed eye drops and change the glasses because there was an improvement in the vision, and a review after a month. On her second visit, she don't have any difficulty while the reading, but she still have photophobia and tearing. So we thought the eye drops was not working. So discontinue the eye drops and change her glasses to the photograph, looking at her photophobia and tearing symptoms, and a review after 3 months. After 3 months, she becomes symptoms free, even though her cornea one remains unchanged. So we can see how the photograph glasses has removed her photophobic and tearing symptoms. To conclude my slides, so we can see here the peripheral retinoscopy has a great role in post-trauma refraction and in photochromic glasses to relieve the photophobic symptoms. In case of the
1 minute left.
In case of the post-trauma cases, most of the time it is associated with the highest astigmatism. If vision improves after prescribing the high astig, it will easily acceptable by the patient. So we should not hesitate to prescribe the higher astig. Thank you.
Thank you very much, AJ. That's a great start to the allied health section of our conference. And I think these two cases really highlight very well how the treatment after ocular trauma doesn't stop, and the important role again that that allied health can play. So the next of our speakers who's going to be speaking is Narayanan Rajiv, and he'll be speaking on mastering toric GP lenses for corneal scarring. Rajiv is from Singapore. He's from Singapore Polytechnic. Thank you, Rajiv.
Thank you. Am I audible, please? Am I audible?
Yes, a bit louder would be great.
Am I audible?
Yes, you are.
Okay. Hi. Hello, everybody. Thank you for the invitation. I have no financial disclosure to make. In line with the theme of this conference, I've conveniently included a couple of corneal laceration pictures because these are the patients who might come to us or corneal toric lens, also for their aphakia correction. Again, there is sufficient evidence to prove that contact lenses, particularly RGPs, play a significant role in correction of astigmatism and aphakia. And there's more evidence from the literature too. So I was given this topic on toric lens, and there are too many confounding factors. For example, the visual outcome, success outcome, depends on size of the opacity, density of the opacity, and also the location and more. So what I've done is to focus purely on toric or GP lens with the particular emphasis on astigmatism. Our goal when we fit a toric or GP lens is to avoid having significant bearing so that we can have a beautiful lens fit, which gives good comfort and vision for the patient. So when it comes to toric or GP lenses, there are 3 types of lenses: front toric, back toric, and bitoric lenses. I will, in this talk, focus only on front and back and bitoric lens. I'm going to take a couple of cases, but please allow me to talk to you as though I'm talking to you as a first-year resident or first-year optometry student. So let's get started with the first case. Patient has K of 3 diopters of astigmatism, while the corneal astigmatism is also 3. So I've taken it such that both are back toric lens. In this case, it is very simple. So what did I do here? Well, this is the spherical power a patient needs along this meridian. And this is the power when you combine sphere and cylinder together along this meridian. Sounds easy, doesn't it? However, there are 2 points to take note. When we do this, visual acuity is going to be perfect only for the first 10 minutes because this lens is not going to move. So we will have to tweak the K readings and the base curve a little bit, but I will not be focusing on that today. Instead, I'll focus on the second challenge, which is induced astigmatism. Let me explain the induced astigmatism part. Please allow me to assume that this is a spherical surface or spherical cornea, while this is an astigmatic surface or astigmatic cornea. So what happens when we have a patient who presents to us with astigmatism? Give them a good specs, your patient is happy, especially with the correct cylindrical amount. So we've done that, we do that day in and out every day. What happens when we give a spherical RGP lens for this patient? When we give a spherical RGP, again, we all know that the tear lens significantly corrects the astigmatism for these patients. But today, our focus is on toric lens. So what happens if I give this patient who has significant corneal astigmatism with a good toric lens, which nicely matches the corneal curvature? When we do that, it's not the primal lens that corrects the astigmatism. Instead, it is the material or the lens itself. So when this happens, we inadvertently induce astigmatism. So let's try to calculate the astigmatism now. There is a conversion factor that we can use to calculate the astigmatism. This depends on the refractive index of the lens. So for example, if we decide to fit a Boston 4 lens, which has about 1.5 refractive index, the conversion factor is 1.4. So coming back to our first case, our intention was to correct 3 diopters of astigmatism. But what we ended up doing is to overcorrect because of this induced astigmatism. So what do we do in this case? How do we tackle this case? This could easily be tackled by incorporating a front toric lens for this patient. So the front toric lens power should be about plus 120. So it kind of compensates. So to conclude the first case, our intention originally was to start with a back toric lens, but we ended up giving a bitoric lens, which would not only have a good fit, but also would enhance the visual acuity of the patient. This is the second case. I'm keeping it very simple. No significant changes, but only change I've made here is to showcase that this patient has about 425 astigmatism, although his corneal astigmatism is only about 300. So here, the induced astigmatism sort of compensates the internal astigmatism for this patient. So in this case, back toric is a good choice. My final case for today is a simple case that presented to me a couple of years ago. A patient came to me with 3 diopters of astigmatism, regular astigmatism in both the eyes. I started with a soft toric lens. Fit was good, but patient wasn't happy with the quality of vision. But when I shifted the patient to a spherical RGP lens, visual acuity was okay, 6, 7.5. However, the patient was not able to use the lens for more than 4 or 5 hours a day. And every time she visited me, there was also significant 3 and 9 o'clock staining. Once I shifted this patient to a bitoric lens, the fit was so good. Comfort was good, visual acuity was good. The fit was such that
1 minute left.
It looked as though I fitted a spherical cornea with a spherical lens. Indeed, you and I know that this is a toric lens. In summary, toric RGPs should be actively considered by us whenever we deal with higher astigmatic patients, whether or not they have corneal scar. Empirical order is a good start, and please do closely work with local lens manufacturers because they are very handy, especially when things don't go very well, they take responsibility on your behalf. Lastly, most importantly, if some of you are keen to learn more about toric lens and other specialty lenses, GP Lens Institute has vast amount of resources in terms of calculator, webinars, and more. Thank you for your attention.
Thank you very much, Rajiv. That was a great set of examples, those patients with induced astigmatism and the real difference that you can make with RGPs. And of course, in the context of trauma, for many patients, this is often an issue. So this can make a really big difference to their final visual outcome. So the next speaker we'll move to is Syria Walid. She's going to be speaking on post-traumatic prosthetic fitting. Syria is from also from Singapore, NUH, and I'll hand over to Syria. Thank you very much.
Hang on. Hi, good afternoon, everyone. Thank you for inviting me for APOTS virtual conference. I would like to share with you the prosthesis, ocular prosthesis trauma. I have no financial disclosure. Okay, these are the topics that I'm going to share in my presentation. As all knows about ophthalmic trauma, ocular trauma, severity cases like simple, intermediate, and complex. Okay, the most important goals of ocularis, there are mechanical trauma, chemical or burn injuries, Stevens-Johnson syndrome. Semaphore rings are also called from open formix conformer. It helps to prevent the lids touching the cornea for chemical burns, and for chemical burns and avulsion of the conjunctiva, it keeps the eyelids away from the irritated eye. I produce this customized semaphore rings for our patient and also the needs of our doctors. Post-traumatic persis bulbi, soft socket, folding slip, and well-formed for scleral shell. For this patient, I fitted scleral shell for him, and it's nicely seated on the socket with good eye movement. For scleral shells, it's not more than 3 mm thickness. Enucleations, these are some of the problems that leads to enucleations. Okay, prevention of sympathetic ophthalmia, persis bulbi, microphthalmia, retinoblastoma, large meneloma, blind painful eye, post-cataract glaucoma, retina surgery. My point of view for ocular prosthesis are seated well for after the enucleation done, and I have done the ocular prosthesis for all these patients. Good post-traumatic anatomic sockets, automatic surgery, good ruptured, reconstruct the socket. As you can see, these sockets are too small. Okay, it's quite difficult for me to put a prosthesis for this patient, but I have to make it very, very small in order to sit on the socket itself. the good size implant, as you can see, is full volume and shape with good phonics, deep phonics. And also the prosthesis will sit nicely in the socket as well. Okay, for iris painted conformer, usually after this nucleation, we usually put the phonics conformer to maintain the phonics. Customized ocular prosthesis is also a good eye movement where the prosthesis can sit well in the socket itself with less rotations and more realistic look, and give self-confidence to the patient. Okay, I'm going to share with you the first case. Okay, this is a direct and simple case, which is 45 years old Chinese, blunt versus sharp eye injury. Okay, this picture shows you the iPhone that his spectacle which broke and cut his left eye, blind, disfigured left eye, corneal scleral laceration repair, persist bulby for this patient, observation trial scleral shell, Gunderson flap, enucleation and implant may be considered. Okay, the next one, okay, this is a persist bulby patient, which is I mentioned before. Okay, with shrunken eye with white eye here. Okay, it's very direct and very simple, not so difficult, where the prosthesis is seated well for this patient. And I noticed that the eye movement is very good. And the patient is very happy with the outcome. Case number 2 is intermediate by this girl, a 17 years old Malay girl. She been hit by the baton while playing rugby. Eye globe rupture with loss into ocular tissue, persist bulby or tropion. Emergency right globe rupture repair. Right lower lids ephemeron correction with tarsal strip. Observation, bicycle eye, ocular prosthesis is done for her. As you can see, this is the testicle eye with very sunken, and I need to do a prosthesis for her with full of volume for the prosthesis. The first eye was done is a little bit too big and a little bit lower eyelid laxity. And the second, which is I have done for her about 6 months after the first prosthesis was done, it looks better, and rotation-wise are less, and also the prosthesis is seated very well. The patients are happy with the outcome as well.
1 minute left.
Okay, last case will be 62 years old Chinese, facial eye injury caused by high pressure hydraulic pipe, okay, with lower lids and facial restoration. Okay, for these patients, as you can see, the MRI with no eyeball and ruptured globe. Okay, this is the patient that I mentioned just now. Okay, it's really quite full volume there, and the prosthesis was done for him is really very small. And I have to done 3 times for this patient. It's very quite tricky, and the first prosthesis was done for him is a little bit too big, okay, with the iris slightly bigger than the other one, and the second prosthesis was done for him, and I noticed that it's a more sunken at the back.
Time up.
Okay, and the third one is the patient happy with the prosthesis. Okay, the good complex and outcome. Okay, as you can see, this patient is also the ultimate socket, whereby the patient have done the prosthesis. I have done prosthesis for him, and it's really good, nice shape and seated well there. Okay, conclusion. You may also reduce it by using the acrylic for modifying the prosthesis itself. Okay, thank you. This is my mentor, Dr. Shawan, for guiding me throughout. And
sorry, Dr. Wallet, can you please wrap up?
Thank you.
Thank you very much, Surya. I think these cases really highlight the very broad range of different mechanisms. I can't believe somebody got injured by the iPhone, which is quite an unusual one, I would think. But again, in all seriousness, I think the implications of the aesthetic outcome way beyond vision are really important, and I really congratulate you on your work. Thank you very much. So the next speaker I'm going to pass on to is Eros Rosikan. He's going to be speaking about preparing donor corneal tissue in emergency cases. He's from Indonesia, and he's part of the wonderful work that they do at the Jakarta Eye Centre. Thank you very much, Eros. So you just need to stop sharing your screen, please. Thank you. So over to you, Eros.
Okay. Thank you to the APOTS 2020 committee who trust me to deliver the presentation preparing donor corneal tissues in emergency cases.
Dr. Oskin, will you go full screen?
Wait.
Yeah.
I'm sorry.
Yes.
As we already know that corneal injuries is divided into two parts. One, traumatic occurs due to corneal abrasion and foreign bodies, and two, exposure-related burns from chemical, thermal, and radiation sources. Etiology. The following is etiology of corneal injury. One, abrasion and foreign body, including fingernail, contact lens wear, brains, and two, perforation, like saws, grinder, and bonding metal object. And then the three is burn, like chemical, acid, and alkali burns, radiation burns for ultraviolet sources, and thermal burns. This is the donor eligibility related to COVID-19. Regarding the COVID-19 pandemic, we will use screening potential donor who have died, including history of disease, symptoms, experience, symptoms of COVID-19, have ever had contact with COVID-19 patient, had traveled abroad in the near future before, if from the result of the screening, there are suspicion that lead to COVID-19, donor cornea cannot be taken. And then this is basic guidelines Excision cornea donor related to COVID-19 that I'm take from EBAA. The first is no report case of transmission of SARS-CoV-2, MERS-CoV, or any other coronavirus via transportation of ocular tissues. Current medical standard of the ABAA requires use of double povidone iodine donor prep. Povidone iodine has documented in vitro vitricial activity against coronavirus. Increased testing of patients is in the hospital and outpatient setting for COVID-19, and greater understanding of COVID-19 symptoms will enhance donor screening and the safety of the safety of donor tissues. Scope of Indonesian Eye Bank, apart from being the Eye Bank regulator Indonesia, Eye Bank activities include promotion and education for screening potential donor, excision of the donor cornea, endothelium assessment, screening for HIV, hepatitis B, C, and syphilis, donor corneal cytellum assessment, safe storage processes, and process of distributing the donor cornea to the eye bank branch to or hospital where it is needed. This is excision corneal donor procedure. Before the excision corneal is taken, what we have to do is ask for approval from the family of the prospective prospective donor. Even though the deceased has a donor card or is registered as a potential donor, but the family does not agree to take the cornea, the process of taking is cancelled. The corneal retrieval process is not long. It only takes only 10 minutes. The cornea will be better if it's taken in less than 6 hours. The sooner is removed, the better the quality the cornea. The cornea removal does not cause disability or bleeding, and then taking the cornea must be done carefully to maintain the quality of the cornea. This is the cornea have been medium preservation. The cornea that have been removed are interested into the optical GS preservation medium, which can store the cornea for up to 14 days. After the cornea is removed, we cover it again using transparent eye caps, so it will look neat. And on the edge of the transparent eye caps, there is a protruding part that serves to hold the eyelids, so that the eye look beauty like a sleeping person. In the following, we present the corneal data that we obtained in 2017, where the number of corneas used in Indonesia is still dominated by foreign donor, namely from the Philippine eye banks, and local donors only range from 2 to 6 corneas per month. In 2018, we made several breakthroughs to increase the number of corneal recoveries with activities such as corneal donor campaigns in community and campus. Eye bank technician training batch. We also get a eye bank technician training batch. 1 to 3 sessions. There are 70 eye bank technician in Indonesia, and this
1 minute left.
As shown result where donor processing had outperformed donor from the Philippines and Nepal, namely 5 to 28 cornea per month. The number of cornea obtained in 2019. In 2019, the acquisition of local donors still outperformed donor from Nepal and the Philippines, namely in the range of 6 to 20 corneas per month. Keratoplasty, as we all know, the indication for keratoplasty are divided into 4, namely optical, therapeutic, tectonic, and cosmetic. In emergency case, we try to have an optical quality cornea, but if this is not available, the use of the grade B or C corneas is understandable. The main objective of keratoplasty in the case is
time up
to save patient will maintain structure and integrity.
Sorry, Dr. Rosikan, can you please time up?
Okay, 1 minute.
Eros, we might have to finish there. If you want to just go to your very last slide. I think you highlight some really important points regarding the current challenges, but it sounds like with the large number of eye bank technicians that you have, it's really going to make a big difference in terms of outcomes there. Do you want to, is that your very last slide?
Yeah, one slide again. This is.
But so we're going to have to close it there so we can move on to the next speaker.
Okay.
And then we're going to go to questions at the end. So if you want to, once we come to the panel discussion, if you want to just highlight your final points when we come to that, we'll give you an opportunity to do that. But just so we don't run out of time, we'll keep going. But thank you again for your presentation, Eros. So next we're going to move on to Agus Rianto, and he's going to be speaking about low vision management in ophthalmic trauma. Agus is from Indonesia, and he's again from Jakarta Eye Center. Thank you very much, Agus.
Thank you, moderator. Good afternoon. I would like to share with low vision management in ophthalmic trauma. Backgrounds: ophthalmic trauma is one of the causes of low vision and blindness. Based on the ophthalmologist's examination, the visual acuity less than 6/18, the light perception, patients are classified as a low vision. The visual acuity, non-light perception, patients are classified as a blind. Definition of low vision by WHO: a person with low vision is one of has impaired of visual function even after treatment, surgery, and standard refractive correction, has visual acuity less than 6/18 to light perception of visual field less than 10 degrees from point of fixation in a better eye, but who has potential able to vision for planning and execution of the task. Low vision management: clinical assessment and functional assessment to determine best correction, distant and near glasses needed. Prescription for glasses, low vision devices, optic, non-optic, and electronic. Visual function, contrast sensitivity test, illumination, color vision, visual field effect, recommendation, and prescription. Prescription of low vision devices, glasses and microscopic glasses, hand or stand magnifier, telescope, non-optic, extra light, lens filter for glare, and etc. Electric magnifier or gadget. Training, low vision devices training, visual aesthetic training, orientation and mobility training, evaluation and follow-up. Functional assessment, orientation and mobility, indoor or outdoor, learning media, print, braille or combination, and modification of environment. Psychosocial counseling, refer to psychologists, social worker, and refer to peer group. Follow-up and evaluation, evaluation for visual acuity, evaluation for low vision devices, advice to teacher, classroom, if patient, student, refer to ophthalmologist. Example, case 1, toxic optic neuropathy or alcohol. Before intervention, 70 years old, male, student, high school, problem, visual acuity 2/60 OD and OS non-light perception. Can read whiteboard, near 3M at 10 centimeter, contrast sensitivity is low contrast 20% with Pelly-Robson. Intervention with glasses, minus separis, minus 0.60, cylinder 0.50, and visual acuity 2.60, and OS plano. Addition +2 can read 2.5 M at 50 centimeter, and hand magnifier 60 diopter of 4 times. Telescope 10 times. Improve visual acuity 3.6 matrix. Can read whiteboard. Advice to present. Case 2, toxic alcohol prevention. 30 years old, male, profession SEP, problem, visual acuity 1/60 ODS, can read whiteboard, near 6 metric at 20 centimeter, low contrast, glare in outdoor. After intervention, glass minus 3, cylinder 0.5, axis 85, and OS minus 2.5, cylinder 0.50, and 12 not improved. Electric magnifier can read textbook, non-optic filter lens for Polaroid, pulper, glare, and final modification. and training, orientation, and mobility. Conclusion, low vision management is a part of ophthalmic trauma service. Collaboration between ophthalmologists, optometrists, rehab worker, and other professions must be needed to improve quality for patient. Thank you for your attention.
Thank you very much, Agus. It's a very interesting presentation and definitely a key part in making sure that the outcomes from ocular trauma, again, that we can achieve the maximum vision possible. I'll just remind you again, if you have any questions, to add them to the chat bar and we'll deal with them at the end. We'll be having a panel discussion right at the end. So I'm going to move now to our final speaker. We have Bob McQuaid. I'm delighted to be able to invite Bob to speak about amniotic membrane in ophthalmic trauma. Bob has positions both in the US, in one of my favorite cities in Denver, as well as in Thailand. So I'll hand over to Bob. Thank you very much.
Thank you, Annette.
The same session, no, there's some session going on after this.
Just a reminder to turn your microphones off, and thanks again, Bob.
So good morning from Denver to all, where it's almost 4 o'clock. I'm honored and excited to be awake and speaking. I thank you for taking the time to zoom into this talk. I'm going to speak on Procara. It's a self-retained cryopreserved amniotic membrane. Self-retained in that it does not need to be glued or sutured into the ocular surface or the mucous membranes of the lids. It is worn like a contact lens. It's cryopreserved at low temperature as opposed to being desiccated or dehydrated with heat, which will reduce the biological activity of the amniotic membrane. And it being worn as a contact lens makes it much easier to use in office. It's an in-office procedure. It takes seconds to insert and remove. I have no disclosures to make, and amniotic membrane was first used in 1910 for as a dressing for wounds and burns. In 1940s, it was first used on the ocular surface for a short period of time. Perhaps it was difficult to acquire fresh amniotic membrane when you needed it in an emergency, but it was the Russians in the early 80s who started using amniotic membrane again. In 1995 and 97, there were 2 papers reviewing that amniotic membrane could be used to reconstruct the ocular surface, and again, clinically to treat persistent epithelial defects and corneal ulcers. And amniotic membrane now is supplied by women who are in a prenatal clinic who are having a planned cesarean delivery. Their medical and social history is reviewed. They're screened for health and social history, and within a week of delivery, they have serological testing done to make sure there's no communicable disease. And that's repeated at 6 months post-delivery to make sure there's no latent conversion. Procara is the company, is the lens. It's supplied by BioTissue Inc. in Miami, Florida, and it's prepared in a proprietary manner with storage solution and glycerol that allows it to be stored as low as minus 80 degrees centigrade. The US FDA considers it a class 2 medical device, and as a tissue, it does not have to go through pre-market approval. So here are some images from BioTissue on Procara and amniotic membrane, A being amniotic membrane as it might be used in surgery intraoperatively. You can see the sheet there. B is amniotic umbilical tissue used as a wound dressing and in glaucoma surgery for shunts. C is the Procara Plus. So Procara Plus is a 2-layer amniotic membrane and a little bit thicker, heavier polymer clip like a symblepharon ring for a more intensive therapy. D is Procara Slim, which is the most popular application. It's a single layer of amniotic membrane and a much lower profile amniotic symblepharon ring. E is Procara Clear, which is a slim with the central aperture, so there's an unobstructed visual axis. My Procara representative says she's never had to supply a Procara Clear. She supplies very, very few Procara Pluses. The vast majority of Procara lens applications use a Procera Slim. And it's wearing a Procera lens, acts as a bandage on the eye, bandage contact lens. However, it is the unique biological activity of amniotic membrane that makes Procera such a unique therapy. There's many growth factors and this unique molecule, the hyaluron pentraxin 3, which has tremendous anti-scarring and antivascular capabilities. Procera downregulates the inflammatory signaling cascade. It promotes apoptosis of activated neutrophils, lymphocytes, and macrophages, and it is supplied in that 16 millimeter diameter symblepharon ring. Amniotic membrane varies from 75 to 150 microns thick. In the US, it's approved for almost for a month. Mostly patients wear it for between 2 and 7 days. So Procera not only suppresses the inflammatory response, it stimulates scarless corneal healing and increased innervation of the cornea. So it has epidermal growth factors and cytokines and chemokines that, along with the hyaluron pentraxin 3 molecule, that stimulate good cell division, promotes corneal avascularity, which maintains transparency, reduces scarring, and it stimulates epithelialization or reepithelialization of the cornea. So for persistent epithelial defects and limbal stem cell deficiencies, it does wonders to promote normalization of that cornea. The nerve growth factors stimulate nerve cell growth in the cornea. Confocal microscopy studies have shown that the subbasal nerve plexus has significant improvement in nerve fiber density when Procera has been worn, and it reduces pain. So if you think of that lacrimal functional unit where there's sensory information from the trigeminal nerve in the cornea influencing production of tears, the aqueous, mucin, and lipid component, which bathes and nourishes the corneal surface, it improves that feedback loop so you get better tearing and a happier eye. So there are many clinical uses for Procera. A lot of these are surgical. In our office, used mostly for dry eye disease, filamentary keratitis, recurrent erosions, persistent epithelial defects, neuropathic corneal pain, and neovascularization of the cornea from both herpes simplex keratitis and for ocular rosacea. I have a patient with Salzman's degeneration right now who wears it, and she is ecstatic with the change in comfort she's had having Procera on her eye. So here's a little video from biotissue showing insertion and removal of Procera. It comes in a little flat pack. It takes up minimal space in a freezer. It's a cold chain supply, has to be maintained. You'd have to take it out 5 or 10 minutes before use and let it sit at room temperature. Removing it, there's the package insert, of course, and documentation facilitating tracking recipient and donor information. The lens is in this convenient little carrier with storage medium. You peel that open, and it's designed to let you pour the storage medium off and irrigate the lens with sterile saline for about 20 seconds is all it takes to remove storage medium, and the device retains the Procera lens. You irrigate it and then just remove the retaining clip and have the Procera lens sitting there. You can pick that up, inspect it for no gross abnormalities. Use topical anesthetic to numb the eye. It's not particularly uncomfortable, just dulls that blink reflex. So have the patient look down, pull the lid up and insert the Procera into the superior fornix. Make sure it's tucked in behind the lower eyelid. You inspect it to make sure it's sitting well on the eye and moves well. You can stain with sodium fluorescein, and you can evaluate the cornea through the amniotic membrane. To remove it, you numb the eye, have the patient look up, use a pair of tweezers to pick up the inferior edge, and then say look straight ahead. You slip the lens out without scuffing the cornea. I also will use a tape soraphy. This is tegaderm tape on the lateral aspect. Improves comfort, at least for especially that first day of wearing time. Again, here's removal with the patient looking down, using tweezers to pick the lens up off, and as the patient looks straight ahead, you again avoid scuffing the corneal surface. So I recommend using a toothed forcep or tweezers to pick the lens up. Smooth forceps slip off that polymer ring. It makes it a little bit more awkward to get the lens out. So this is a 56-year-old female who came in with classic burning eye complaints. Colorado is really a semi-arid environment in an office with air conditioning or in the summer and heat in the winter blowing across the eye. It exacerbates that dryness. So she's on artificial tears, gels, ointments, cyclosporin drops with minimal relief. You can see her cornea here looks pretty messy with marked PEK. So we discussed at length dry eye. And again, patient education is critical over there. I recommended to try the Procare in the left eye. We inserted it and applied a tape Sorafie with the Tegaderm tape. She came back after 6 days and the cornea was markedly improved. I'd say, trace to 1+ PEK, but more significantly, her symptoms were markedly better. So dry eye, so I moved after 6 days. So the Procare has made treating dry eyes and corneal ocular surface dysfunction much easier to treat. My threshold to use Procare has gone down significantly in the 4 years we've had it in our office. I use it much more readily today than initially, and it can alleviate the need to take severe dry eyes or problematic ocular surface to surgery for a conjunctival flap or surgical tarsorrhaphy. It makes it much easier to treat someone in office. And I have a list of citations here if you're interested in pursuing more information on amniotic membrane and the Procare in particular. So I hope this presentation has been informative, and I thank you for the opportunity.
Thank you very much, Bob, for your presentation. It's really exciting to see a product like this, or this sort of general class of products that can promote scarless corneal healing, and potentially I can see lots of applications in terms of ocular trauma. So if I can ask the speakers from the session to turn on their videos now, and we have just a few moments to deal with questions. So my co-chairs, Daniel and Chawana, have been busily thinking of questions for our speakers. So I'll hand over to them, and yeah, if the speakers can all turn their videos on, so we're ready for that. And thank you again for all of your excellent presentations.
Yeah, can the host put my video streaming on?
Thank you, Annette. So we have heard from the speakers on the diverse management and interventions for post-trauma, both with the aim of preserving the aesthetics and the function of the eye and the tissue. So possibly just to kickstart the discussion, we'd like to ask Ajay from your presentation, when we do peripheral retinoscopy, which can be challenging in eyes with quite significant central opacity. So how do we compensate or modify the cross findings of our peripheral retinoscopy, and how do we start off our subjective refraction from there?
Okay,
Ajay, please.
Thank you for your question. Usually when we'll do the either autoref or retinoscopy, it's the central fovea. So we are refracting the peripheral. So usually the axial length is lesser. So you need to compensate according to that. And most of the time, you need to work on the ST. Usually you go for the spherical equivalent, the vision won't be that significant. So reduce the sphere. And I have seen most of the cases when you will increase the cylinder, the vision will become better and better. So most of the time, you go for the lower, either plus or minus, and bit higher ST. It will give you the better vision in the trauma cases. That's what I have seen it's my experience in refracting with the trauma cases.
Thank you, Ajay. Moving on, the next question is for Rajiv. When in our clinical practice, when we fit GP lenses, so which astigmatism, from your opinion, whether regular or irregular, is masked or can benefit from toric GP lenses? Because when we talk about post-trauma, we can face quite broad clinical situations, particularly corneas with extremely irregular surface and irregular eccentricity. So which one of these two types of astigmatism, whether regular or irregular, can be masked or benefit from GP toric lenses. Rajiv, please.
Thank you, Daniel. By default, toric lenses are given for regular corneal astigmatic patients, but we do see quite a few reports published indicating that they can also be tried in patients where RGP spherical lenses cannot be given. So you could certainly try. And once you, let's say after you try RGP spherical lenses, if there is significant cylindrical over refraction, toric lens is a good choice. So it should still be tried in consultation with the local manufacturers.
Yeah,
Thank you, Rajiv.
I'd like to add a little more on the subject, since we see a lot of trauma where cornea has to be sutured and the irregularity cannot be managed with the RGP lenses. You may consider use of scleral lenses. Scleral lenses is the best choice for irregular astigmatisms or irregular cornea, post-traumatic surgically operated corneas, and you get fantastic results. So scleral lenses is a good choice.
Thank you.
Even adding to the same thing, great talk by Bob on Procera. It's a fantastic tool, amniotic membrane for healing corneal chemical burns or anything. But if you don't have Procera accessible to you, what we have done is we have used the ring, scleral ring that Sue had shown in her presentation. That can be used. You can use the amniotic membrane and put the scleral ring to hold on to the membrane. Also, I have used scleral lens to hold the amniotic membrane on the corneal surface. So good talk by Bob. Daniel.
Thank you, Rajiv and Chawan.
Thank you.
Right, the third question that we have is for Agus. Thanks for your presentation. I'm happy to learn that in Indonesia you can find interdisciplinary low vision services. So maybe from your experience, what are some of the issues and barriers for patients to receive low vision services in the context of Indonesia, if you can share?
Yeah, thank you, Daniel. Yeah, in Indonesia, low vision is must grow because not a hospital has low vision service. In the Jakarta Center, the private hospital is the first established to low vision service, and we have collaboration with the ophthalmologist, rehab worker, and teacher for specialists for the student, because we have program in student and inclusive education. We have the collaboration with the teacher and other community for the low vision service. Thank you.
Thank you, Agus. I'll hand over now to Chawan for further questions, please.
Yeah.
Chawan, please.
Can I just quickly add in one question that's come from the chat for Bob? And the question asks about the use of Procera for chronic dry eye from Sjogren. If you wanted to quickly comment on that. Sorry, Chawan.
Okay.
Sure. I think amniotic membrane on the dry eye with Sjogren's works nice on the ocular surface. Of course, it doesn't do much for the lacrimal gland, which is where some inflammation occurs, but it will certainly heal the ocular surface, at least in the short term. The DREAM study showed that people with marked dry eye, the DREAM study was the dry eye for amniotic membrane study, showed that the 3-month follow-up patients had a markedly improved, basically symptom-free 3-month follow-up after wearing Procera. But again, it will not fix the systemic problems of Sjogren's, but it will certainly smooth out the ocular surface for a short period of time, at least several months.
I guess for dry eye, scleral lens is the best option as of now. May it be Sjogren's or any other reason, Stevens-Johnson syndrome. Scleral lens is the choice of treatment for dry eyes. Coming back to the questions, Sue did fantastic job. Thank you, Sue. for covering all. I must congratulate her because she showed all the difficult cases. My question is, what do you do with simple corneal opacity? How do you manage prosthesis on simple corneal opacity where the cornea is irregular?
Is that question for me?
Sue, that's for Sue.
Sue.
Me?
Yes, Sue.
Oh, okay.
You are ocular.
Okay, hi. Okay, for ptosis, right? What usually I have to do for ptosis patient?
Corneal opacity. Corneal opacity. Total for patients with a total corneal opacity.
Patient for?
Corneal opacity.
From a ptosis.
No, for corneal opacity, Surya.
Or for the corneal capacity. Okay, so
opacity.
Okay, for the corneal wise, what I did is we just do the square shell for the patient, and also the surface of the cornea, right? I have to decrease it, okay, to make it slightly more thinner. So for square shell is quite difficult because it's a very, very thin shell, whereby it's really seated in well there, and it gives you a good movements for the eye. And also I find square shell whereby the thinness, if you can make for square shell, is much more better for the appearance of the patients.
Thank you very much, Surya. I'm in the interest of time, I'm going to pass over to Dr. Arwan, but before I do, I really wanted to thank again all of our speakers today. We've had a really great selection of talks talking about the role of allied health, not just in the treatment, but also in the functional and visual outcomes that they can help with in terms of post-trauma management. And also thank you again to the co-chairs, Daniel and Chawan. So thank you very much, and I'll pass over to Dr. Arwan for a session on retina and uvea. Thank you.
Thanks for the opportunity. Enjoy.
Thank you very much, Annette. So we'll move on to retina session now. And the chair is Dr. Azad, and our co-chairs are Dr. Gridhar and Dr. Chi. So we'll start with the first talk. Dr. Felipe Moreira will be talking on a case of bilateral projectile injury. So Dr. Moreira, would you like to share your screen?
Good morning. Do you see me? Hello?
Yes,
Hello.
it's perfect.
It's perfect?
Yes, perfect, perfect. Yeah.
Okay. Okay. Good afternoon for you and good morning for me. First, I want to thank you all for the invitation, especially Dr. Natarajan and Dr. Ganga to the 5th virtual conference. It's an honor for me to be part of the excellent group of ophthalmologists. I'm Felipe Moreira. I'm the chief of Vitreoretinal Department of San Juan de Dios Hospital. I'm a member of the Pan American Ocular Trauma Association and be part of the Asia Pacific Ophthalmic Trauma. Well, I can. Okay. Well, before we start, I want to explain a little part of Chile's recent history. In October 18, last year, one of the most violent civil mobilization of the last 40 years occurred. Multiple riots developed, which led the violence both for the protesters and the police, who used different methods to disperse crowds. Protesters used incendiary devices and stones during the riots, but the police responds with use of non-lethal weapons in inappropriate ways in some times. According to Sochov is the Ophthalmology Society from Chile, Static reported to the Minister of Health 332 patients had a severe ocular trauma, and 2 of them lost both eyes. In Santiago, the capital, 285 patients received a medical assistance from ophthalmology. In this group, 249 patients were men, the mean age was 29 years old, and 194 received a rubber bullet, and 38 had a complete vision loss of one eye. On another hand, 947 police officers were injured too, of which 87 had a serious damage. Next, I want to talk about the crowd-controlled rubber bullets. In relation to their composition, they are made 20% of rubber and 80% of different kinds of metals. When used, police officers, they have to follow a protocol to use them correctly. They should be a fair distance to 25 to 30 meters, for this, or as this reduce the risk of serious injuries and should be made to the lower third of the body. Another kind of crowd control, that's important for the next slide, is the smoke bomb. This bomb is fired by a shotgun, reaching a speed of up to 6 kilometers per hour. Consider an approximate weight to 500 grams. This can sometimes be a little weapon. Because of this, it should be made to the ground. This case is the several case I have. The following case is a 36-year-old female who was her way to work when she encountered a riot and received a trauma on her facial area, presenting immediately bilateral vision loss. She was admitted to a trauma hospital and they called me. On initial evaluation, frontal nasal trauma with bilateral orbital involvement was noted. Open TBI was also observed. On ophthalmic evaluations, she presented with bilateral eyelid wound, bilateral open orbital fracture, ruptured globe for the right side, and probably open globe injury of the left eye with total edema. Future evaluation was reserved for the operation room. Surgery in the operation rooms lasted for 6 hours. Eyelid repair without graft was performed. Bilateral operolacrimal duct repairs with a tape. Medial canthus repair was not possible because of the destruction of the bone structure as seen on CT. In the right side, scleral suture were done with uveal tissue removal, followed by orbital implant placement. The left eye had a severe damage with complete absence of uveal tissue, but for psychological reason, scleral suture is performed to attempt a globe salvage. After psychological management, evisceration will be done. But that's the problem. What's next? Aesthetic management is very important, not only for the patient, but also for her family, which is why evisceration will be done on the her eye with the eyes. Traumatic ptosis, partial reconstruction will also be management. What is the next problem? Unfortunately for the patient, she now has also anosmia and dysgeusia. On this image, we can see
1 minute left.
These symptoms are producing in this trauma. For all these reasons, integral management is very important. This complex patient should be show immediately early psychological treatment, including their family. Rehabilitation is also important as soon as possible when the prognosis is known. In conclusion, several ocular trauma management is always multidisciplinary. Management includes psychological intervention and rehabilitation. Treatment should involve family and close people. Treating physician must accompany the patient through the present and the future process, including intervention of mental health specialists. In severe ocular trauma with frontal involvement, always consider the taste, smell, and behavioral disruption. Thank you for your time, and that's.
Thank you very much, Dr. Moreira, for your nice talk. And these are the procedures definitely which require more multidisciplinary approach and maybe requiring multiple procedures. Thank you very much. So now we would like to move to Dr. Hua Yan, who is going to talk about etiogenic retinal trauma and its management. Dr. Hua Yan, would you like to share your screen, please?
Thank you, Felipe, and thank you, Hua. Hua, you can see you. How are you? You have to unmute, Hua. You have to unmute yourself.
Hello, doctor. Hello, doctor.
Yes, we can hear you.
No, you have to unmute yourself.
Dr. Hua, on the Zoom platform, you just touch it, or with the mouse you take it and unmute yourself. You'll see a mute thing there. Unmute yourself.
Show your screen, please.
In the screen, on the screen, you will see a mute, unmute. Can you unmute yourself? Yeah, doctor, I think we can go to the next speaker, please.
Okay, no problem at all. So we'll move on to Dr. Geeta Lisa. She's going to talk about. Okay. Yeah, that's fine. That's fine. We can hear you. Yeah. Dr. Yan?
I just want to say hello to everybody. I know all of you. And, good afternoon to all of you.
Are you able to share your screen, Dr. Yan, or we can move to next talk and we'll come back to you then later?
Yeah,
okay.
Yes.
Yeah, that's right. That's right. Okay. Dr. Yan, please unmute yourself.
Dr. Yan, take the help of Chang for yourself.
Yeah, okay. Dr. Yan, can you unmute yourself?
He is being shown as unmuted.
Sir, he's having difficulties in his connection.
Okay.
So we suggest him we suggest him to join again.
No. That's okay. Now, Navneet, yeah, Chang is there. Dr. Yuan, can you ask Chang to come on the screen? I will guide him. Chang, please come on the screen, please.
Sir, he's having difficulties in his connection.
Okay, maybe we'll go to the next speaker. I'll stop sharing the screen. You can go to the next one. You can go to the next speaker.
Thank you.
May I share? Okay.
Dr. Geeta Lisa is going to talk about what's new with traumatic macular hole. And please share your screen. Thank you.
Thank you, Dr. Amirawan. Could you see my slides?
Yes,
absolutely. We can see it.
And your voice? My voice,
yes, we can hear you.
Yes, sorry.
We can hear you.
Okay, so thank you. So thank you, Dr. Awan. Thank you, APOTS, for inviting me. It's such an honor. I will talk about what's new with traumatic macular holes. I have no financial disclosure. I will start my presentation by two cases. The first case is a male, 38-year-old with right eye traumatic macular hole after hit by a ball 1 week earlier. After observing him for 1 month, we decided to do a vitrectomy with ILM peeling. So we did internal limiting membrane peeling using brilliant blue dye. And with the peeling technique is the conventional flap. And I tried to do the peeling as extensive as possible. And afterwards we did fluid exchange. And in the end, I put C3F8 gas tamponade and put the patient on prone position. This is the image from pre-op. We can see a full thickness macular hole with some subretinal fluid here. And then the vision was 6/40. And after surgery, The vision was 6/9, and we can see that the hole is closed, and the image, the appearance of the macula is quite good with some minimal residual subretinal fluid. The next case is a 54-year-old male with left eye traumatic macular hole and accompanied with retinal detachment after hit by a shuttlecock several weeks earlier. So we did the surgery right away, 23 gauge PVV with ILM peeling, again using a brilliant blue dye, and it's a bit difficult doing peeling in a detached retina, but we did it, and we did a drainage retinotomy, and the retina was flat at the end of surgery, and we put C3F8 glass and applied laser surrounding the break and 360. And this is the appearance. So we did, this is the image before surgery. We can see retinal detachment and full thickness macular hole with edema, cystic changes at the edge of the hole. The vision was 6/30, and this is post-op. We can see that the macula looks quite nice, and the vision is 6/9. So basically, traumatic macular holes are a full thickness fovea defect frequently associated with sports and work-related accidents causing blunt trauma, and it can be caused by other causes as listed here, and it occurs mostly in men and young age in their second to third decade, and it occurs in 1.4% of closed globe injuries and 0.15% of open globe injuries. The onset is fast. It could occur immediately up to a few weeks, and 85% of cases present without PVD. The diagnosis is quite easy. The patient usually comes with blurred vision, ranging from 20/80 to 2400. Sometimes they will have metamorphopsia or central scotoma, and we can easily see the hole with the fundus exam. But it may be complicated by choroidal or retinal pathologies such as retinal detachment, vitreous hemorrhage, or choroidal rupture. And high resolution OCT is important a diagnostic tool because it can show the full thickness hole, the size, the cystic retinal changes, and other pathologies. So the issue with the management of traumatic macular hole is whether to observe or do surgery right away. A series by Chen and co-workers compared observation for 6 months versus early vitrectomy, and it is found that in the group with observation only, spontaneous closure was reached in almost 70% of cases, while in the early vitrectomy, the anatomic closure was 100% with ILM peeling. And another series by Tang and co-workers also showed good anatomical results, more than 90% of hole closure, and almost all eyes improved their vision to 15 letters or more, and two-thirds of the patients gained 20/80 or better. So the general consensus is to do watchful waiting for 1 to 3 months, although some would advise longer, up to 6 months, and terminate observation, do surgery if the symptoms persist, the hole enlarge, or the visual acuity declines. So these are, how about the use of adjuvant therapies? So some authors use platelet concentrate, TGF-beta2, and also serum to assist chorioretinal adhesion. However, judging by the numbers also, it is not determined whether the addition of these substances could improve the effectiveness of vitrectomy. In pediatric patients with traumatic macular hole, however, Wu and co-workers showed that plasmin-assisted vitreolysis to aid PVD induction in pediatric traumatic macular holes yield good results with a closure of 92%. And how about newer approaches to in the management of traumatic macular hole? The new surgical technique is do an inverted flap ILM peeling, where the partially peeled ILM creates a closure to the wound, to the macular hole, showed by the OCT image in your right here. And a novel approach also by Rizzo and co-workers, published in Retina 2019, showed that human amniotic membrane plug placed in the subretinal space is useful to bridge the tissue gap and provide a scaffold for the retinal tissue to overfill and close the macular hole, as shown in
1 minute left.
pictures. Okay. Intraoperative OCT is also proven useful because it could assist the VR surgeon when to peel or not, when to use tamponade agents or not, because if only with vitrectomy and elevation of hyaloid the hole is closed, then we need not do these procedures which can potentially cause complications as well. So prognostic factors in traumatic macular hole, the favorable predictors for spontaneous closure are young age, small holes, no presence of PVD, no presence of ERM, absence of intraretinal cysts, and no accompanying injuries such as ERMs and choroidal rupture. While predictors for worse visual outcome in traumatic macular holes are ellipsoid band attenuation in pre-op OCT, as shown in this OCT, larger holes, poor preoperative visual acuity, accompanying retinal pathologies. Photoreceptor and RP damage may limit functional outcome despite successful anatomical closure. So in conclusion, traumatic macular hole is a combination of ocular injury, which may be vision threatening. High resolution OCT is important. Observation is prudent in young patients with smaller holes and no other pathologies. Surgical management with vitrectomy and iLM peeling achieves excellent outcome, and final VA depends on photoreceptor and RPE damage, regardless of hole closure. Thank you. Sorry for
Thank you very much.
overtime. Thank you.
Thank you very much, Dr. Geetaliza, for your nice talk. So next speaker would be Dr. Hussain Khakan, who will talk on small gauge vitrectomy for intraocular foreign bodies. Dr. Khakan, would you like to share your screen, please?
Yes, please. So I'm sharing my screen. First, Geeta will close. Yeah.
Dr. Geetaliza, can you stop sharing your screen? Yeah, that's fine. Thank you.
So is it visible?
Yes, doctor. Go ahead.
Yes, yes,
Please.
visible. Yes.
Please.
Thank you, APOTS. Thank you, Professor Natarajan and Professor Rajvardhan Azad, and my dear Amir and Rupesh and Ganga for inviting me for this talk. My talk is about 5 minutes plus little bit. It's about intraocular foreign body. I will share the different techniques and different ideas how to remove the different size and different shapes of intraocular foreign body. So I have no financial interest in presenting this presentation. My case one, this is preoperative images. Patient have a corneal scar and cataract. Preoperative CT scan shows intraocular foreign body. We are doing lens matter aspiration. And we started 23 gauge pars plana vitrectomy. Dense vitreous hemorrhage has been removed. Here you can see a large metallic intraocular foreign body lying anterior retina inferiorly. I'm holding with the end grasping forceps. You can see the huge size of intraocular foreign body, and then you can remove it from the corneal wound. So as this patient was aphakic and there was deficient posterior capsule, so we removed it from the limbal or corneal wound. So there are different approaches. So this is second case. Patient has a large intraocular foreign body. You can see the almost similar scenario, dense vitreous hemorrhage, but the hair scenario is little bit different. The large intraocular foreign body here you can see is deeply embedded inside the retina and choroid. I am just dislodging it, and then after the dislodging it, I am picking it up with the end grasping forceps. You can see a large metallic piece of about corneal diameter, about 10 millimeter. So I remove it through the pars plana by enlarging the sclerostomies. These are the pre-op images of my third case. It is different from the previous two. This is not a large foreign body. Here you can see a small size foreign body, but it is deeply embedded in the retina and choroid. So here you can see it's a not large but small one. So this is pseudophakic eye, so I am removing it by enlarging sclerostomy through the pars plana. So this is post-op image of this case. The case 4. This is severely traumatized eye. Multiple surgeries have been done, and the patient presented to us with a retinal detachment, and intraocular foreign body is lying over the macula in subretinal space. It is subretinal space, so I dislodged foreign body with a soft tip extrusion needle away from the macula and did the retinectomy to remove it from the subretinal space. So here you can see I am doing cautery of the retina, and then I am doing small retinectomy to remove this large subretinal intraocular body. This is soft tip extrusion needle that I'm using to displace it. And here you can see when it's under the retinectomy area, I'm using the claw forceps to hold it, as it's very large size. So I have 23 gauge large size claw foreign body forceps. So here you can see the huge size of foreign body that is lying subretinal space. So then as this eye is aphakic, so I have to enlarge and remove it from the limbal wound. Our next case is similar with the cataract corneal scar repair done, so have to remove the cataract. So here the foreign body, as you see, it was lying in the dense hemorrhage, and when I cut the hemorrhage, it just fell over the macular area. So be careful while doing the vitrectomy. If it is dense hemorrhage, you can end up in a foreign body may be displaced, or it may be fall over the macular area. Next is our sixth case. In this, this is old trauma, not fresh hemorrhage. This is fibrosed area, where you can see the lesson here is that I am picking this foreign body, metallic foreign body, with the magnetic claw forceps. This is the magnetic forceps that we have designed it.
Pre-recorded lesson come up.
So here you can, I am not.
Sorry, can you switch off your unmute yourself, please?
The magnet, I am just lifting it and putting it over the hemorrhage area. So, and then again picking it. So what's the benefit of this magnet forceps is that you don't need to hold it or scratch over the retina. You can just easily lift it up and then bring it out. This is small foreign body, intraocular foreign body, metallic, lying in the mid-vitreous cavity. Very easy to remove, but what happens sometimes, as it is easy, it becomes very difficult. I lost it in the sclerostomy. Then the trick here is you have to do the indentation, and during indentation, you see I found it lying over the ora serrata area. Then I dislodged it in the vitreous cavity, and again hold it with and grasping forceps. So if you lose the ventricular foreign body while removing at the sclerostomy area, so it is important to do the indentation, because it may be lying over the anterior retina or vitreous base. These were few tricks and tips that we can use for the different size and different place of intraocular foreign body. For large foreign body, for lying over the retina, for lying inside the retina, lying under the retina, and if you lose the intraocular foreign body in somewhere in the mid-vitreous. That's all from my side. If I have any questions, so I am here. Thank you so much, everyone, for having me here and for your patience. Thank you.
Thank you very much, Hakan, for your nice, short and sweet talk. So we'll move on to next talk. Dr. Lam will talk about managing posterior segment trauma in children. So Dr. Lam, would you like to share your screen, please?
Yes, please. Dr. Kakan, can you stop sharing your screen so I can share Professor Lam's video?
Yes, please.
Thank you for the kind invitation to participate.
Oh, sorry.
I think something happened to screen
Kendrick,
sharing.
Can you
do it again?
Yeah, sorry. Sorry about that. I think the session went wrong. Okay, there.
Thank you for the kind invitation to participate. I don't have any relevant financial. Looking at different epidemiological study, children are involved in about 40% of the trauma related to hospitalizations in the world. That the incidence of sport-related injury is increased as one gets older, so as that related to the use of toy guns. On the other hand, the injury related to the cleaning products has declined with age, as the children realize that they are not candy despite the colorful package. The cause of pediatric ocular trauma are many, and projectile account for the 20%. There are also unusual causes for the pediatric ocular trauma, such as rooster's attack, door handle, pencil tips, chopsticks, and microwave eggs. There are also injury related to specific cultures and geographic locations, such as snowball injury in Finland. Open group injury account for 2 to 4 per 100,000 in the US. The ratio between boys and girls is about 2 to 1 to 5 to 1. Most of this occur at home, although in the developing country, it occurs also more in the outdoor and in the street. Penetrating injury account for the most common injury ranges more than 50% of the cases. Zone 1 injury, meaning that locating between the cornea and the limbus, account for more than 50% of the cases. Interestingly, the Zone 3 injury, which is the posterior segment injury, is associated with worse visual prognosis. Ocular signs associated with open globe injury can be either very obvious, such as the peak pupil or the low intraocular pressure, or subtle in terms of non-specific redness or irritations. But we should always be alert to the less obvious signs. Intraocular foreign body should be suspected with history of explosions or hammering metal on metal. And in the case of suspicious of intraocular foreign body, cautions should be taken for the intraocular pressure measurement, and the fundoscopy should be done without scleral depressions. CT scan is usually the initial choice. MRI is reserved for those non-metallic foreign body. X-ray and B-scan can be done, but it should be done with cautions and also be gentle for the risk of causing more injury to the eye. Here are a couple of retinal findings associated with blunt posterior trauma. The commotional retina is the contusive injury to the retina causing retinal edema. On the other hand, for the case of retinitis scopoperia, as shown in this here, is often associated with presence of retinal contusions and choroidal contusions associated with extensive subretinal and retinal hemorrhages. This was thought to be due to the shock wave generated by the high-speed missile injury to the globe and causing the injury to the sclera and resulting the retinal contusions. Once the blood absorbed, the injury area often fill in with scar tissues and pigmentary changes. Traumatic retinal detachment is one of the consequences of ocular trauma. Sarrazin studied 138 patients with retinal detachment, compared the outcomes of 56 children, ranged between 4 months old to 18 years of age, with a traumatic etiology. There were 37 eyes with open globe injury and 23 eyes with closed globe injury. The outcome of both eyes were poor. The only predictor for the 20/200 or better visions is the preoperative macular attachment. On the other hand, intraocular foreign body, age, preoperative visual acuity, number of surgery, or time of the diagnosis are not significant in predicting the visual outcome. Here is a 12-year-old girl with a Smith-Magenis syndrome with history of a behavioral problem, high myopia. She presented with chronic closed fundal detachment in the left eye with a giant retinal tear, and thought to be related to self-inflicted injury. Self-inflicted injury is a common cause of pediatric retinal detachment from the blunt trauma. You can see there was a closed fundal retinal detachment with very severe PVR and giant retinal tear. You can see removing the vitreous, allowing the meticular dissections of the membrane. Viscoelastic was used to help to flatten out some of the area to allow the dissections of the membrane in those areas. Once the retina is flattened further, heavy liquid was injected to flatten the detachment further and allow additional dissections of the preretinal membrane. Once the membrane is flattened, then laser is applied to the posterior edges of the retinal bricks and any suspicious area. And you can see the retina at this point is flattened, which is a dramatic difference from the beginning. So it's important to also check and treat the other eye. They often require additional treatment because the other eye might have either subtle finding or actually similar trauma injury to the eye. And for instance, for this girl, she needed laser treatment for the other eye also. Silicone oil is used in preference over gas because it's more stable and less dependent on positioning. And you have to be wary of using retinectomy in the children because the thick retina and the tendency for the retina to curve in. In children, the meticulous membrane dissection is the key to allow the retina to get flat. And interestingly, this young lady, the post-op visual acuity returned to 20/200. So never give up on children. So take-home message is that if you suspect occult open globe injury, be wary of the subtle finding.
1 minute left.
Always look out for those. So even the non-specific redness irritation may be a clue for an occult open globe injury. Important to do imaging to rule out intracranial foreign body if the history is suggestive. And need to be aggressive in the management, and if difficult to examine, EUA may be required. And the surgery may be required to perform in stages, and you may not need to do all things at the same time and deal with the cataract, the cornea, and the vitreous hemorrhage in a sequential fashion. Thank you for your attention.
Thank you very much, Dr. Lam, for your nice talk. Dr. Yan, I believe, is ready for his talk. So it's on iatrogenic retinal trauma and management. Dr. Yan, would you like to share your screen?
Yeah. Hello, Dr. Natarajan, Azad, and Amar, everybody from good evening. Or APOTS. Today I'm talking about the iatrogenic retinal trauma and the management. And, refracting is always used for the treatment of PDR, PVR, ocular trauma, macular, or any other disease. So I divide into the reasons of iatrogenic retinal trauma into 3 types. And the first one is the myeloperation during retractomy, and the second one is the myeloperation in other intraocular surgeries, and the last one by instruments. When we do the retractomy and the operation by PVD and repair the epiretinal membrane with the forceps, or by the cutter for aspiration and the tear of the retina, and or with myeloperation of the use of retinal photocoagulation, or overuse of cryotherapy, or inappropriate use of retinectomy or retinotomy. Another one is the myeloperation during the phacoemulsification, like lens dislocation or intraocular lens dislocation. So I will show you 2 cases. The first case is the iatrogenic retinal trauma by the intraocular lens dislocation during phacoemulsification. So this patient was female and 71 years old, and the vision decreased in both eyes for 2 years with any trauma or pain. And when we use the city time examination, the lens is opacity, and the intraocular pressure is normal, and the diagnosis is cataract. So let's see the video. So this is a normal cataract surgery. So first of all, make a clear corneal incision and inject the hyalurone and do the capsulorhexis and do the phaco. It's very easy. And do the irrigation aspiration. So at the end of phacoemulsification, you can see when you use the injection to seal the corneal incision, what happened to see here. Okay, suddenly, what happened? So the doctor used the injection in the clear corneal incision. What happened? Where's the lens? Where's the needle? And then you can see what happened? The vitreous hemorrhage. The color is right, just in the center of pupil area. So the doctor called me, Dr. Yan, what should we do at this time? I just tell them, close the wound and stop the surgery. So the second day, the best grade visual acuity is 0.2, and you can see slight hyphema and vitreous hemorrhage. And the 7 days after primary surgery, I performed the retractomy. Okay, this is the retractomy for this patient. So at this time, the intraocular lens dislocated and crashed to the retina. And first of all, I remove the anterior segment of the vitreous, and then remove the hemorrhage, and try my best to find out where is the intraocular lens. Where is the intraocular lens? Maybe here, here, or here. I'm not sure. So I try my best to remove the peripheral area. So here, this is iatrogenic retinal trauma. by the crash of the intraocular lens at this area. So I have to do the laser photocoagulation to close the retinal tear. However, there is no retinal detachment, just the retinal tear here. And then I injected the perfluorocarbon liquids to move the intraocular lens up, and up to the pupil area. So when I use the perfluorocarbon liquids to move the intraocular lens up and to the pupil area, just to use the Sinskey hook from the anterior segment, and then rotate the intraocular lens just anterior before to the anterior capsular rhexis, and then fix it there. So the surgery is finished. So finally, the final result, the best corrected visual acuity is 0.7, and the intraocular pressure is normal. This is a slit lamp examination and the photo for this. Corneal clear. So I will show you the second case. This is a traumatic retinal trauma during refracting for lens dislocation. So this is a very easy case, just a lens dislocation case. So the doctor in my department just
One minute left.
Okay. And then this is the trauma, retinal trauma here, and the closed wound. And then I perform the surgery. So I try my best to see where is the iatrogenic retinal trauma. So here, this is iatrogenic retinal trauma during dislocation of the lens surgery. And then I remove the hemorrhage on the surface of the retina and do the laser treatment and perform the air fluid exchange and inject the silicone oil and then finish the surgery. Okay, thank you so much. This is our family of the APOTS. Thank you so much.
Thank you very much, Dr. Yan. So now it will be my pleasure and honor to introduce Dr. Peter McCloskey, who is head and chair of ophthalmology at University of Sydney. And he's going to talk about sympathetic ophthalmia in 2020. Still relevant. Dr. McCloskey, please share your screen.
Yeah, great. I'm just waiting for the others. Now I can. Terrific. Thank you very much. It's a real pleasure to be part of this meeting, and good evening from Sydney, Australia, where I am at the moment. So I was asked to talk about sympathetic ophthalmia, and is it still relevant in 2020? And it certainly is. Although it's a rare disease, it's a bad disease, and I want to explain to you tonight why sympathetic ophthalmia is still relevant and important. As we know, it's been recognized for millennia. It was first recognized by Hippocrates. Archimedes, back in ancient Greece, also used to deliberately infect horse eyes with dung to give them severe intraocular infection, as it was believed that prevented sympathetic ophthalmia. We know Louis Braille went blind from sympathetic ophthalmia, and our modern understanding of sympathetic ophthalmia began with descriptions by Mackenzie and Fuchs. Obviously, there has to be a history of eye trauma. If both eyes are present, a bilateral granulomatous panuveitis. We have the concept of an exciting and a sympathizing eye. And importantly, the incidence and prevalence of sympathetic ophthalmia has progressively decreased over the past 250 years. And this slide from my friend and colleague Anthony Hall in Melbourne, it just plots the incidence of sympathetic ophthalmia after penetrating eye injuries. We know that in the American Civil War, it was about 4 in 1,000. By World War I, it was down to between 2 and 3. World War II, it was down to less than a half a person per 1,000. And in the Korean, Vietnam, and Iraq-Iran wars, there were no cases of sympathetic ophthalmia, despite, as our colleague from Chile showed us, the increasing frequency of ocular trauma in civil unrest and in wartime. So sympathetic ophthalmia is a rare disease. The prospective surveillance audit in the UK showed that it was basically about 1 case per 3 million. in a large series following trauma from South Africa. Again, it was very, very low, and the same after multiple VR surgery, where the frequency is extremely low. Interestingly now, in the UK series, the commonest cause of sympathetic ophthalmia was vitreoretinal surgery, not trauma. So what are the clinical features of sympathetic ophthalmia? It's a granulomatous panuveitis. So you see granulomatous KPs, anterior segment inflammation, vitreocellular infiltrate, and these very typical small multiple focal choroidal infiltrates, so-called Dalen-Fuchs nodules. Severe disease, you'll get exudative retinal detachment, hyperemic swollen discs, macular edema. Sympathetic ophthalmia shares many of its clinical features with VKH disease. Multimodal imaging has made it much easier for us to detect and diagnose sympathetic ophthalmia. Clinically, early on, the best place to look for inflammation in traumatized eyes is in the anterior vitreous, in that sort of retrolental space. The patients become photophobic, and then that's where you usually first start to see lenses. But with multimodal imaging, we can detect a thickened choroid, because sympathetic ophthalmia is a choroidal disease primarily. We can measure it accurately now with EDI-OCT, and you get these really characteristic features on fluorescein and ICG angiogram, multiple pinpoint starry night type appearance with fluorescein, and these persistent hypocynosant granulomatous lesions that are visible on ICG. So to make the diagnosis, clearly there must be a history of trauma or surgery, and as I said, usually vitreoretinal surgery. We need to have a high index of suspicion to make the diagnosis and follow our patients after trauma and make sure we examine both eyes. Occasionally, it may be important and necessary to exclude syphilis and sarcoid as possible diagnoses. I mentioned earlier that infection used to be thought to be protective, but a very nice series from Narsingh Rao showed that that's not the case. So these days in 2020, what are the key steps for minimizing sympathetic ophthalmia? The first is expert microsurgical repair. Basically, the decision to keep or remove an eye is decided on a patient-by-patient basis on the clinical features and surgical factors that are involved in whether an eye or not is salvageable. If an eye needs to be removed, both enucleation and evisceration are safe. Evisceration is the technique that's used most commonly and certainly gives the best cosmesis. The medical management has improved enormously. We know that sympathetic ophthalmia is a severe vision-threatening form of uveitis. There may only be one seeing eye, so we manage these patients with aggressive systemic therapy, and it's typically combination immunomodulatory therapy. So oral steroids to begin with, and then second agents such as methotrexate or mycophenolate. In severe disease, as long as there's no possibility of infection, we'll use IV methylprednisolone. And now, of course, with the advent of biologics, we have some really powerful second agent drugs in biologics to help control the inflammation. Modern sort of immunosuppressive therapy has really greatly improved the outcome of sympathetic ophthalmia. But this case series from Jennifer Thorne has really shows that what a severe disease it is. A quarter of the patients presented with poor vision of less than 660 in the sympathizing eye. The significant risk of vision loss at 10% per person year following diagnosis. In round numbers, 50% of the patients with sympathetic ophthalmia had significant complications at the time of their presentation, and the development of complications, particularly cataract and retinal problems, occur at the rate of 40% per person year. The factor that we know is that's associated with a poor outcome is an exudative retinal detachment, because there's often then extensive outer retinal damage. But all of that said, basically nearly 60% of patients had a visual outcome of 6/12 or better, and 75% of patients had a visual outcome of 660 or better. So modern treatment for sympathetic ophthalmia has made a big improvement in the outcomes. So I'll finish by just briefly reviewing the pathology and what we think is the pathophysiology. As I mentioned, it's a granulomatous chronic inflammatory disease characterized by multinucleated giant cells, macrophages, T cells and B cells. And we know that pigment and RPE cells are engulfed and are present within the nodules. We know that what happens is that initially there's an innate immune response, which then generates a T cell mediated pathological response, which becomes dominant and drives sympathetic ophthalmia. So very quickly, I'll just remind you about the differences between innate and adaptive immunity. Innate immunity is present basically in all multicellular organisms. It's been with us since the evolution of multicellular organisms. It's characterized by a system that recognizes what are called pattern-associated molecular patterns or damage-associated molecular patterns. It has a very rapid onset of action within hours, and it has lots of soluble effectors such as cytokines, chemokines, complements, and the effector cells are our white cells and our macrophages. It only gives a localized protection wherever innate immunity occurs. It damages the tissue in that area, and there's no immunological memory. Innate immune responses are identical each time, whereas adaptive immune responses, which occur only in vertebrates, are antigen specific. They take up to 2 weeks to develop. The effector cells are T's and B cells, and antibodies are the principal cellular effector. It protects the entire host. It causes minimal injury. And the most important thing is immunological memory, which is why vaccination is such a useful thing. So what happens is that a damage from an injured eye causes these molecular patterns to be recognized by macrophages, by neutrophils, by antigen presenting cells, and by natural killer cells and a small number of T cells. They generate this
1 minute left.
Thank you. This innate response, which begins in hours. The dendritic cells cause then an adaptive immune response that drives the response. So basically, where are we now? We know that removal of an injured eye doesn't prevent sympathetic ophthalmia. There's no protective time window. The very low incidence of sympathetic ophthalmia is due to expert microsurgical repair and controlling inflammation with steroids and other therapies so that we don't have chronically inflamed eyes. We remove eyes on a case-by-case basis. Immunosuppressive therapy gives us a good outcome in the majority of our patients. So sympathetic ophthalmia is now rare. We know it's an autoimmune disease. We know that removing injured eyes won't prevent sympathetic ophthalmia. The best thing is recognize it earlier and treat it effectively. Thanks very much for your attention. And I'd like to
Thank you very much, Dr. McCluskey.
Thank you.
Thank you very much. Thank you very much. I will appreciate if chairs, co-chairs, and the speakers, they can come on screen and on their audio as well, please.
Thank you.
Right. So,
Mr. McCluskey, I could ask a question.
Sure, Dr.
Thank you very much. Thank you very much.
Thank you. Thank you.
Ferdinand?
Okay, there is a signal issue.
I was just...
I have a question.
So, sorry.
I have a question.
Yes, please carry on.
Can you hear me?
Yeah, I have a question.
Can you hear me?
Peter.
Okay.
I will type.
Can we start?
Please ask the question.
Okay. It's the poor prognosis in sympathetic ophthalmia associated with the late presentation
would say a high index of suspicion and early treatment, aggressive treatment of sympathetic ophthalmia reduce the visual loss in this group of patients?
Yeah, yes, it does. Yeah. I think the key thing is recognizing it early and escalating treatment as necessary to control the inflammatory immune response. It's the same sort of principles that we use for other diseases or other vision-threatening uveitis. So steroids to get on top of the inflammation, and because we know that this is a disease that will need long-term treatment, we introduce a second-line agent such as mycophenolate or methotrexate to act as a steroid-sparing agent and keep the uveitis controlled. And the earlier you can start that, the better.
So would you would you treat this the same way that you would treat KA?
Sorry, can you repeat that?
Would you treat this the same way that you would treat both Koyanagi-Harada syndrome?
Yes, quite similarly. I mean, obviously, like all diseases, there's a range of severity, and you don't. But yes, basically treat it pretty much the same as you would with VKH disease. Yep.
Thanks.
Can I ask one question from the audience, that to Dr. Geeta Lisa, about your first case? I think there was outer retinal defect. What was the real outcome in that case?
The first case. The first case. Yeah. I think the regarding the subretinal fluid, is it, or?
So vision. What was the vision after the surgery?
Oh, the vision is 6/9. 6/9. Okay. Well, the patient was quite happy, and I think it's a young patient, and the lens was still clear the last time I saw him. But yes, we need to follow up these patients, because young patients, he's youngish, almost 40 years old. Maybe he will develop cataract soon, and we need to follow up this patient. And if he develops cataract, then we can advise sooner, so he'll get a better vision.
Yeah, I think the outer retinal defect will disappear with time.
So I
agree.
Amar, I had a question to the first speaker. I mean, and I would like to have the opinion of the panelists. So including the pioneers here, whether doing an evisceration at the time of the initial injury, I would probably suture these cases as much as possible, even if it is very posterior scleral rupture. I would go as much posterior as possible and try to retain the globe and not remove any eye in the primary setting at all. I've never done it in so many years. So I just wanted an opinion from the group and also from the speaker.
Dr. Moreira, would you like to answer?
Yes. Yeah. Okay. Yes, sir.
Yes. I never think the evisceration is the first step. Always I try to suture and preserve the gloves for two reasons. First, for many times you have a several ocular trauma and you think I can do anything, but in sometimes you can win a little, only for anatomic winner. But for example, in my case, when the side eviscerate the left side, the right side, excuse me, is because the gloves is there's no pieces who are their gloves, but always I never do a evisceration in the first time.
Okay.
Well, Dr. Natarajan, you want to say something?
Yeah. Now, Giridhar, I think it's a very good question. We have Ferenc Kuhn here, and I think he's been propagating even no PLIs. We should attempt repair, and then also attempt a secondary, because of the incidence of sympathetic ophthalmia is low. And as Professor McCluskey mentioned, I think it's you can treat them with steroids and immunosuppression. Ferenc, you like to comment?
Thank you.
Yes, I agree that an evisceration or enucleation is an absolutely last resort. And as Felipe said, if the eye can be sutured together, I would not do it, especially not primarily, because for the patient, it's an amputation and it's a huge psychological issue. So initially, if there is something to suture together, do that, and then discuss with the patient the next step.
Thank you. Another question to Dr. McCluskey about how often do you see sympathetic ophthalmitis after multiple surgeries?
The last two cases of sympathetic ophthalmia that I've seen have been after multiple VR surgery. Certainly in my city, VR surgery is now the commonest cause of sympathetic ophthalmia, and I don't mean that in any bad way. It's just the fact that fortunately we don't get that much related to trauma anymore.
Yeah, I agree with you, Professor Peter. I think following vitreoretinal surgery, I've seen sympathetic ophthalmia rather than trauma. Professor Huayan wants to comment, Ahmed.
Yeah,
yes.
Yeah, Dr. Roger. I have a question to Dr. Peter Glasky. So, do you have any better way from the lab test for a sympathetic ophthalmia? Even for the patients with the injured eye or intraocular surgeries, and after several years or 5 years, and that eye have the uveitis, some of the patients maybe with the sympathetic ophthalmia, or some of the patients with the uveitis. So how to differentiate? What's that? In clinic, sometimes, when we ask the patient, do you have the history of intraocular surgery or eye injuries before? And maybe ask, yes, of course. So the other eye with the uveitis. So how to differentiate for that? Thank you so much.
Look, that's a good question. Sometimes it can be hard, but I suppose the absolute thing that you need to make a diagnosis of sympathetic ophthalmia is that it needs to be there needs to be a history of trauma. Sometimes that may not be clear, so you may need to work the patient up depending on exactly what the uveitis looks like. You may need to exclude sarcoid, you may need to think about syphilis, you may need to think about TB, but the sort of clinical features of sympathetic ophthalmia will evolve over time, and the treatment of sympathetic ophthalmia is the same in terms of principles of management as any other disease form of uveitis. There is no diagnostic investigation. There is no, other than histopathology, by actually looking at a non-seeing eye that's been enucleated or eviscerated, can you make the diagnosis? It's a bit like Behçet's disease. There is no diagnostic test for that. It's a clinical diagnosis.
Thank you very much. I think we have to stop here. At the end of the day, we will have more time and we can discuss few more things. Thank you very much to everyone. Thank you.
Thank you.
Ooh, thank you to all the speakers, the chairs, and Dr. Awan. That was an excellent session. So I think before I pass the message to the sponsors, I'd just like to remind everyone about the upcoming quiz that will take place at 8 p.m. Singapore time tonight. If you haven't registered yet, please come in. And if you're a resident or trainee, you can compete for prizes. So thank you. So I'll pass my the message to the sponsors. And then at the end of this, Dr. Akshay will take over as moderator. Thank you, everyone.
Thank you so much. Mr. Navneet and Ashok, if we can have some message from our supporters.
Yes, I'll do that.
Microlabs.
Yes, please. I'm just sharing the slide. Yeah, namaste to all the doctors across the globe. Okay, and I'd like to say on the behalf of Microlabs, I take this opportunity to thank APOTS. And yesterday was the day one, was a superb day, and we are in the middle of the day two. I would like to say thanks to this organization headed by Dr. Gangadhar Sundar and other people for considering Micro Labs to be an academic partner for this wonderful academic initiative. Just to quickly take about my organization to the whole world, because everyone is attending across the globe. We are a leading pharmaceutical company organization in the areas of cardiology, diabetology, psychiatry, critical medicine care, general medicine, and of course, ophthalmology. We are present across the globe from east to west. These are the few countries which I have listed down. We have world-class manufacturing units with all international accreditations. Like when I say international accreditation, in addition to Indian accreditation, it's also the US FDA, MCCA, and Health Canada, etc. Our major strength is our well-equipped R&D. We have 600 scientists engaged in the formulation research. And today, Doctor, Microvision in 2020 successfully completed 2 decades of supporting ophthalmologists in providing best care to patients through our innovative formulations manufactured in self-owned manufacturing unit. This is our manufacturing unit, which is in Bangalore, which is a US FDA approved one. And this is another recently we have started at 2017 at Sikkim, which is a very nice picture place, which is a complete robotic unit. No touch of a human being is taking place when eye drops are coming out of this factory. Dr. Microvision caters to all ophthalmic conditions with its wide range of ophthalmic medications, with a special focus in the areas of dry eyes and glaucoma. Microvision is committed to stay alongside ophthalmologists in extending the best global eye care to the patients. Today, we again say it's a great opportunity to be with us of this conference being of a great clinical relevance, and we wish APOTS a great success. Thank you. Thank you very much.
Thank you so much, sir.
Yeah, thank you, sir.
Yeah.
Thank you.
Right. Our next session is the Ophthalmic Trauma Global Perspectives. May I now invite our session in charge and the architect of this fantastic meet, Dr. Gangadhar Sundar, to join. His chairs are Professor S. Natarajan, along with 2 stalwarts from the Asia-Pacific region, Dr. Hua Yan and Dr. Paisan.
Thank you, Akshay, and thank everybody for a wonderful session that we had just before and the one before that. And I think we had a wonderful participation by Allied Health, which just made it very special. No ocular trauma injury session will be complete without a global perspective. And to bring the global perspective to Asia Pacific, we have the stalwarts of the field from all around the world. And we're going to start off with a nice session by Dr. Rupesh Agarwal, who's going to emphasize the value of gathering data and sharing data and making sense out of it. Following which, on popular demand from audiences from the previous webinars, we have a talk on electrophysiology in trauma, and none other than Professor Graham Holder to educate us about it. We also next have a military ophthalmologist who's going to talk about a new term that I never heard before, damage control ophthalmology. And he's going to share with us in disaster management, what are the essential things any service should be employing upon. And welcome, Dr. Mazzoli. And then we have Dr. Jan Tolma from Pretoria Eye Institute, who's going to share with us what is the state of ophthalmic trauma from the African subcontinent. And finally, the inspiration for me personally and inspiration for APOTS, the reason why we've grown so big today by force is Professor Franz Kuhn, who's going to share with us his journey on ophthalmic. Over to the chairpersons, Dr. Natarajan, Dr. Hua Yan, and Dr. Paisan.
Thank you, Gangadhar, for putting an excellent program. I'm glad, Professor Paisan. Hi.
Hi.
Hi. Hua Yan from China. So we start the session and we invite our General Secretary Rupesh Agarwal to speak on the data.
Thank you, my dear teachers. I think I've got all my teachers, Professor Natarajan, Professor Ganga, Professor Ferenkun, Professor Peter Mikulski is here. I think there are so many, all of my teachers are here on the podium, and I'm learning a lot from Professor Hua Yan and also from Professor Paisan. So thank you for giving me this opportunity. So this has been my favorite topic. And one of the mail shared by Dr. Natarajan yesterday was from 2011 when we were in Sydney. I sent a mail to him that Dr. Natarajan, as a part of APOTS, we need to gather the data. I never thought I will get an opportunity to talk about how much is his journey from 2011 Sydney to March. That was in meeting in March, and then now we are here. This is about the data, and I'm presenting on behalf of Annette Hoskin and a lot of my team members, Rebecca, Dinesh, and a lot of them. And it is very difficult for me to name all those members. Otherwise, the entire presentation will be on that. The only slide which I can probably speak on forever is about this slide number 1, which we do know that trauma is the commonest cause of reversible and most important to me is a preventable visual morbidity. And still, we don't have any training program. We don't have a fellowship to train ophthalmologists for managing trauma. Except this meeting once in a while, we are not having any kind of a structured program. And that led to absence of standardized guidelines. Professor Ferrington, who is on the call as well, and it's my honor to present in front of him. He did a lot of attempt about classifying the trauma and putting together a nice classification, which still holds very true. And still we are working along that. But unfortunately, what is happening is still we are not able to convince a comprehensive ophthalmologist or a hospital to kind of manage a patient of ocular trauma based on these guidelines or any of the existing guidelines. Therefore, that does shows that we need to work more. How do we need to work more? I little bit like to digress the topic which is favorite to myself and Peter Michalski, Professor Peter Michalski, is about the ocular tuberculosis. So this is the field which we did bit of work and in which we don't know the clinical diagnosis, we don't know the treatment, and we don't know the outcome. And still, we don't know anything about the TB. So how did we went ahead addressing? We set up a group called as COTS, which looked into a retrospective study of 900 over patients with Professor Vishali Gupta, Carlos Pavesio, Peter Michalski, and we managed to publish a lot of papers on it. We never stopped there. We went on to set up a COTS-CON, which is a consensus guidelines to formulate when do we start anti-TB therapy. So this is again driven by Andres, who is one of our active member in APOTS, and we managed to kind of come up with the guidelines. When do we start anti-TB therapy in patients with this thing? We also formulated a nomenclature for ocular tuberculosis, which was lacking. And we finally came up with a registry, which we are going to start soon with help of Peter Michalski, Professor Carlos Pavesio from London. And this registry is called as Oasis Registry. So this is just some of those couple of papers. And you can see the number of authors in this particular paper on anterior uveitis, likewise on visual morbidity in patients with the TB. And this is the paper in ophthalmology on guidelines for managing TB choroiditis. So what do we take from here? Why I'm sharing this? So this is a concept which is came up after doing all the work on the TB. And I like to propose the FEMTO, which we can adopt in trauma. And FEMTO stands for, and the number 1 F is the thing of my talk is the facts, which we need to gather the facts, execute it in a proper way with the mentors like Professor Natarajan, Professor Ganga, Professor Kuhn, and gathering a team led by people like Annette Hoskin and all, and to operationalize and present data in front of you. So I will not be presenting any of the data, but I will quickly share what was the concept behind setting up this FEMTO approach or behind setting up this multi-center collaborative study. The objective was to set up a global ocular trauma registry, first time ever, which is really in the global way. And it was just learning from the USEIR and probably Indian Eye Injury Registry and also from POTS from Professor Huayan, which is the Chinese Ocular Trauma Society. Objective number 2 was to set up cases of a patient with ocular trauma. Objective number 3, to also involve survey-based guidelines, which we are doing already, and eventually to come up with an AI-based model for doing up a CDSS, which is Clinical Decision Support System. So this is where we are collecting the data, and the idea is to move into to set up a IGATES registry where we will doing a prospective based, and eventually to put in an AI algorithm where all the images and the data will go into a model, and where we will be able to come up with a predictive algorithms, prediction API, image analysis API, and classification API to come up with a classification of a trauma based on the AI model. This is
1 minute left.
Are there in our with the efforts from the work from Professor Rekha Khandelwal from Nagpur, and this is the first paper of the IGATES group looking at the outcome in central India. And there are other few papers in line, which is done by work by Annette. This is some of the work which is presented at ARVO meeting, and schematics which can't share in this particular presentation, but I have shared that at multiple different presentations about the schematics. To end up, I would like to take inspiration from a couple of my publication. The one is about the digital epidemiology written by my student and my very good friend Dinesh, who actually helped me revolutionize this management of the guidelines which we set up for COTS, and he also helped me with the form of IGITS, and a very recent paper on COVID research, how do we kind of collaborate and do a clinical trial with a new normal. Thank you very much for your patient listening.
Thank you, Rupesh. And next we invite Professor Graham Holder to speak on electrophysiology, one of the, I think, the authority in the world we have. Professor Graham. Yes. Good evening, Graham.
Good evening. We should now be there. Great. It's a pleasure and a privilege to be part of this meeting. Am I audible?
Yes, you're audible.
Thank you. Ocular trauma, as we know, is common, and over the last few sessions and yesterday, we've heard some very good talks on various aspects of it. So what is the role of electrophysiology? Well, electrophysiology provides an objective assessment of function. It provides localization and quantification of dysfunction. And of course, in the acute phase, it's of extremely limited value, where surgical priorities must be of paramount importance. People who are going to use electrophysiology are encouraged to use standardized techniques and to be adequately trained. And I mean both the technician and the person doing the interpretation. Specialty training is important. Now, it's beyond the scale of this talk, which is very short, to go through the origins of the signals. But just very briefly, the full field ERG is the response of the masked retina to a luminance stimulus, with the ERG A wave primarily coming from retinal photoreceptors and the B wave coming from the inner nuclear layer. The macula is a small area, lots of density in terms of photoreceptors, but very small, and does not significantly contribute to the full field ERG. And if you lose macular function completely, your full field ERG will not be affected. We use a pattern ERG for assessment of the macula, sometimes multifocal ERG, more about that later. And of course, the VEP, which comes from the back of the head, very sensitive to dysfunction, useless in terms of specificity. As a downstream response, it can be affected by the chiasm, the nerve, the macula, the lens opacity, corneal opacity, poor refraction, dirty spectacles, etc. Pattern ERG is important because it enables both a measure of the macula from the P50 component and also the N95 component directly arises in the ganglion cells. So we get the only measure directly of central ganglion cell function available in electrophysiology. Most of the pattern ERG comes from the ganglion cells, but it's driven by macular photoreceptors. One of the questions that is often asked of electrophysiology is a patient with reduced visual acuity, is it genuine? And non-organic visual loss is where the electrophysiology really comes into play by demonstrating normal function when symptoms suggest otherwise. This is a 32-year-old who had reduced vision following a traffic accident, litigation was pending, and pattern ERG is bilaterally normal and symmetrical. So there's no evidence to explain the counting fingers right eye from macular or ganglion cell dysfunction. The pattern VEP from the left eye is completely normal. That from the right eye is delayed and small, but is detectable, which it should not be with an acuity of counting fingers. However, when you're doing pattern VEPs, the technician must be very vigilant. They have to watch the patient, and it was obvious that the patient was trying to manipulate things. She was closing her eyes, she was deliberately changing fixation, she was trying to distort the image, etc. And when she was observed and aware she was observed and told to keep looking at the center of the screen, to keep concentrating and do what she was supposed to do, the response is completely normal from the right eye. And this was deliberate manipulation by the patient. So this was an attempt to deceive. But some patients will probably try and exaggerate their visual loss, not to deceive, but to enhance or explain or convince. This is an air conditioning engineer. It may just be the fact that he spoke minimal English, had work trauma with very nasty physical damage. Repair was done, but it was not possible to explain the light perception on the basis of the physical condition of the eye following the initial repair. We did pattern VEPs with a view to looking at prognostic information, and there is a pattern VEP detectable from the right eye, which there should not be with light perception if this is genuine acuity loss. Flash VEP is actually less, probably slightly better than that from the fellow eye. And then we do pattern ERGs, and they are almost completely extinguished, normal from the other side. But of course, this is a patient who doesn't have a lens, who has marked optical factors. So although the pattern VEP preservation confirms the acuity to be better, what it doesn't do is tell us about the relationship with the optics. And we can use then a focal ERG using large squares instead of small squares, but it's still an isoluminant checkerboard reversal. There's no luminance change. And then we see the presence of a focal ERG. This confirms that there is macular function and there is no contraindication for surgery. Trauma, of course, can often be associated with metallic foreign bodies. We've seen elegant descriptions of how to remove them. And this is a patient who was referred with possible siderosis. Acuity was still good at 6.9. There are mild changes on autofluorescence imaging, mild changes in terms of fundus color. And when we look at the ERG, the rod-specific ERG, these are now the international standard for main ERGs. I don't have time to go into, you have to trust me on this. The rod-specific ERG is undetectable. The bright flash dark adapted ERG has mild reduction in the A wave and marked reduction in the B wave. So this is an electronegative waveform. Flicker ERG is normal peak time, but markedly subnormal amplitude. And these findings are entirely consistent with siderosis, and the patient needs surgery. Sometimes you will find a foreign body becomes completely encapsulated. There's sometimes no need to remove this. If the ERG is normal and stable over time, it can just sit there quite happily. This is a patient who was referred following a head injury, hit by falling wood while at work, then complained of constricted visual fields, fundi were normal, and referred by the neuro-ophthalmologist, and the VEPs are delayed. The delay in this instance is consequent upon reduction in macular function. And when we did full field ERG, this again has an electronegative waveform, but quite different in morphology. Here it's a very, very smooth, large A wave with a smaller B wave. There's no oscillatory potentials. The flicker ERG is very delayed. And this is not typical of the sort of siderotic appearance. But what is important is that one of the routines for the technicians taking a history when the patient comes, the patient was epileptic. Nobody had considered this. He was on vigabatrin, and these ERGs are diagnostic, in context anyway, of vigabatrin toxicity. Absolutely typical. Take a good history. This is a Chinese male, 72 years of age, referred with pigmentary deposition. The query at the referral said possible unilateral RP. This is in fact an extremely rare disorder. There's only one genetically determined case in the literature of proven unilateral RP, and it's best described as unilateral pigmentary retinopathy. We published a series on this a couple of years ago, and one of the causes, of course, of pigmentary retinopathy is trauma. Patient's got a previous history of branch vein occlusion in the left eye. It's the right eye which has the RP type picture, and it is an RP type picture when you just look at the imaging. There is pigmentary deposition, there's hyperautofluorescence. The other eye is normal other than the vein occlusions. When we look at the ERGs, there's loss of the A wave in the bright flash, so this is photoreceptor dysfunction. There is generalized dysfunction in the cone system showed by the delay. And this is entirely in keeping with a photoreceptor problem, but the left eye is completely normal. This is a unilateral pigmentary retinopathy. And then direct questioning of the patient, he said, oh yes, well, my right eye's been bad for a long time. Something happened to it with trauma when I was fishing when I was a child. So this is long-standing. Again, take a history. Another patient, previously diagnosed with left optic atrophy, and the reason this looks blurred is that this is a photocopy of the referral. Quote, on examination, evidence of mottled RPE pigmentation, bone spicules suggest a unilateral rod cone dystrophy. On direct questioning again, there was a history of trauma in the left eye, age 13. He had a very bad injury with a football. There are some changes in the left eye, but nothing particularly dramatic. But when you look at the OCT, he's lost the foveal contour. The inner retina looks a mess. And when we do the ERGs and VEPs, there is a delay in the VEP from the left eye. This is consequent upon loss of macular function. This in itself is consequent upon generalized retinal dysfunction. The rod-specific ERG is small. There's a profoundly electronegative bright flash under dark adaptation with A wave involvement. Cone ERGs are very, very small with marked delay, and this is entirely in keeping with a central retinal artery occlusion. So this is a traumatic left CRA. And
1 minute left.
Ferenc Kuhn, who is speaking later, has described this. The last case is a patient with a long-standing history of traumatic optic neuropathy, ganglion cell loss on the OCT, N95 loss in the pattern ERG with no VEP, consistent with ganglion cell retrograde degeneration. When we do the ERGs, marked loss of the rod functions, that's what explains why the patient is night blind, but we need to say where is this stimulus response coming from. When we do a red flash, we see a cone component but no rod component, so this is a cone isolated retina. Further history taking, patient had a Whipple procedure and therefore has vitamin A deficiency due to loss of pancreatic enzymes and vitamin deficiency. ERGs, of course, this is treatable, normalized following intramuscular vitamin A. So to conclude, ERGs are invaluable to provide objective demonstration of function. They enable localization and quantification of dysfunction. That assists diagnosis. It informs management and enables management decisions to be taken. But to go back to Suzanne's talk yesterday, always take a full and accurate history. There's no excuse for clinical inadequacy. Thank you very much indeed.
Thank you, Graham, for a wonderful overview on the electrophysiology. Now we have Dr. Robert Mazzoli to speak on damage control ophthalmology. Gangadhar Sundar is going to play the video, and we have Dr. Robert Mazzoli also in the panel.
Sir, you can't hear the audio. Yeah. Maybe you have to go to the audio thing, tap, and then play from the computer audio. Ashok, can you guide?
Yeah, once again. Doctor, while sharing the thing, just stop sharing now. Stop sharing. While sharing, when you click on the share button, you'll see down, share the computer sound. Click on that, check on that, and then click on the presentation.
So you're also muted, so in case you're seeing.
Right, sorry. So I share screen first?
No. First you have to click on the button, share screen, click on the check button, the computer sound.
Okay.
No, stop sharing, doctor. Please stop sharing.
Prof. Mazzoli, you can stop sharing screen, and then Dr. Ganga can play for you.
Yeah, Dr. Ganga, please, when you click on the share screen,
yeah,
you will see down a computer sound on the down.
Yes.
Thing. Yeah, click on that and then share. Take the presentation.
Share computer sound. Yes, got it.
Yes, yeah.
So
please
sorry
go. Yeah, go ahead, sir.
Let me go back.
Focus on immediate measures that
you would have to click on the yes.
Okay.
Thank you. I'd like to thank the organizers for the opportunity to speak about damage control ophthalmology, a different philosophy and approach to managing ocular trauma, and even a way of restructuring our teaching about trauma, particularly in emergency conditions such as we saw recently in Beirut. I have no financial disclosures. Damage control is a naval term that describes certain specific, well-defined immediate measures designed to minimize damage and prevent the ship from sinking. They focus on immediate measures that deal with emergencies only, with a focus on maintaining critical systems such as power, steering, navigation, and communications, with definitive repairs deferred until later. Importantly, these measures are routinely practiced and rehearsed on board. We can apply a similar philosophy to certain ophthalmic emergency situations and trauma where our immediate focus is not on complete definitive repair at the first intention, but rather focuses efforts to minimize immediate damage to the eye. We concentrate on emergency measures only, a concept tied to ocular triage, with the goal of restoring ocular integrity and maintaining vital ocular structures and functions, such as the cornea, retina, optic nerve, lid and orbit, controlling intraocular pressure, and in preventing infection. We are allowed to intentionally defer more definitive measures. The concept of damage control in trauma and ocular trauma is not new. Although the military has always practiced some version of damage control, Rotondo and colleagues in the early 90s formally applied the terms damage control surgery and resuscitation to specific first actions for trauma, formally prioritizing life-saving steps over definitive measures. Kuhn and Associates described a similar approach for ocular trauma. The military practices DCO because its reliance on successive echelons of care usually precludes definitive treatment at the point of injury. Under this concept and design, emergency surgery is performed at forward facilities aimed at saving and stabilizing the eye for evacuation, while successively more capable facilities along the evacuation chain perform more sophisticated and definitive revisions and repairs. DCO principles apply in situations where we face limitations of time or capability, when you as the ophthalmologist and surgeon are not in control of the trauma situation, when resources are overwhelmed, such as in Beirut or Boston, or in other crises. Limitations of time refers to when the time available does not permit definitive care. An example is in mass casualty situations, where the number of casualties overwhelms your capacity to treat them. Note that the threshold of mass cal does not hinge on a specific number of casualties. 3 casualties may overwhelm your capacity and is therefore a mass cal. In these scenarios, interventions are tied inextricably to ocular triage. Faced with multiple casualties, with the goal being to do as much for as many as possible, the time available to treat any single patient is limited, which necessarily limits your interventions to basic stabilization, or what trauma surgeons previously referred to as meatball surgery. You can't spend 6 hours on one patient and leave 10 others waiting. Another example of time limitation is if evacuation is imminent or expected, such as if working in an echelons of care trauma system, even in civilian medicine. A strong argument can be made that definitive surgery should be deferred when the capability to provide that level of care is limited. For example, if the surgeon lacks the expertise to handle the degree of trauma, or if it requires a higher degree of specialty skill than the surgeon possesses, then that definitive repair should be deferred and referred after foundational DCO. For example, consider the situation of oculoplastic specialists faced with a complex open globe with foreign body repair. Similarly, in cases of ocular polytrauma, where multiple structures are damaged and which would best benefit from subspecialist treatment or a team of subspecialists, then all involved should be comfortable with the definitive repair being deferred to the higher capability after initial stabilization. Other considerations that limit capability might be if one is faced with insufficient or improper personnel, supplies, logistics, or equipment. For example, if you routinely operate at a standalone eye center with all of the appropriate state-of-the-art amenities, but find yourself responding to a trauma at the general hospital with only a neurosurgical scope, no viscoelastics, personnel unfamiliar with ophthalmic instruments and techniques, and no sutures smaller than 7/0, that may not be the optimal or appropriate place to attempt definitive surgery, even if you have the needed skill. Yet another circumstance where DCO may be appropriate is when infrastructure is damaged, such as in natural or man-made disasters, industrial accidents, or other austere conditions that significantly degrade capabilities. A surprisingly common scenario apropos DCO and limited intervention occurs when you as the ophthalmic surgeon are actually not in charge of the overall situation. For example, in systemic polytrauma casualties, particularly in mass cal and certainly in combat, several surgical teams and specialties may be operating on the same patient simultaneously. This may limit your ability to even simply access the patient with the scope. Colleague surgeons may jostle the body, creating an earthquake tremor under the scope. A neurosurgical intervention may limit what you can do. Or trauma surgeons may decide the patient has to go to the ICU before you have the time to do everything needed. Similarly, a patient may decompensate and become physiologically too unstable to continue, with anesthesia calling a halt. In all of these scenarios, you are not in control and you have to limit what you can do. It's clear then that there are various characteristics of DCO, primarily a reliance on teamwork and staged procedures, These aspects are most evident when working in a trauma system based on escalating echelons of care, with increasing sophistication along the continuum. This awareness can help set realistic expectations for the care provided at each level. As a practical matter, DCO means you don't have to win the trauma war all alone or all at one sitting. You're part of a team, contributing your share and playing your role, and able to rely on your teammates to provide their support at a subsequent time. As previously stated, the role of DCO is one of minimal surgery with the goal of initially stabilizing the globe. This surgery sets the foundation for later repairs and revisions. These may be performed by others, but may actually be done by you in a different setting, time, and place that affords more control. Again, DCO is not meant to be definitive, although it certainly can be. Similarly, a critically important aspect of DCO also includes knowing what not to do under DCO conditions. There are several aspects which DCO principles address. Necessity. How critical is a step, procedure, or repair to saving the eye? This is something that is absolutely required prior to leaving the OR that must be addressed prior to terminating, or can the step be deferred, temporized, or avoided? Urgency. If a defect must be addressed, within what time frame must it be accomplished? Does intervention happen within minutes, such as canthotomy canthelysis and orbital compartment syndrome? Hours, as in open globe repair? Days, as in canalicular laceration repair? Or weeks, as in orbital repair? Adequacy. This addresses the meticulousness of the repair. This may be based, for example, on the ability to revise the wound. If the first repair is the final repair, then the level of meticulousness may be high. But if faced with a stellate corneoscleral laceration with significant intraocular tissue prolapse, accurately aligning the limbus may require meticulous attention, but astigmatically neutral sutures may not need be a primary concern. If a wound can be revised, temporizing sutures may be sufficient for DCO. And as mentioned, it is critically important to know what not to do during DCO. This may not using porous implants in contaminated orbits and sockets, deferring intraocular foreign body removal for later, not doing primary corneal grafting versus using adjuncts to seal the wound, etc. This also includes not burning someone else's bridge in your desire to do everything, especially if you know a different specialist is coming after you. Don't shoot that specialist's favorite never fails silver bullet procedure and force them to use an alternative technique when they inherit the patient, such as not doing a Hughes flap at the
1 minute left.
DCO is a concept that has to be developed and promoted. As we do so, we have to develop specific DCO principles and steps, as the navies have done with their shipboard damage control. We have to identify essential actions and priorities, keeping in mind the considerations of necessity, urgency, adequacy, and avoidance. We then need to identify critical knowledge, skills, and abilities for those steps, along with identifying needed equipment, personnel, and supplies to accomplish those steps. That may mean developing portable DCO trauma contingency kits. In developing these principles and guidelines, it's essential to write and teach from a DCO perspective, from the perspective of the generalist or the other specialist under duress, as opposed to from our own subspecialist's perch, and consider their capabilities and potential limitations. In that light, as we write general trauma texts and make our own presentations,
Time up.
I would encourage that we consider including DCO aspects in addition to, or perhaps instead of, focusing exclusively on the definitive tertiary care ivory tower level instructions. Finally and critically, DCO is something that has to be intentionally and specifically taught and rehearsed by all ocular trauma surgeons. Thank you for your attention.
Thank you, Ganga, for projecting. And I think we will move, very important topic, I think, is the do's and don'ts of ophthalmology, not only trauma, damage control ophthalmology. So we go to the next, another interesting talk by Professor Jan Talma. And I think he was with us yesterday also from South Africa, an ophthalmic trauma and Africa perspective.
Thank you for the opportunity. Mr. Chair, I think there is a video that can be played.
Ganga, you're playing?
Yes, I'm just trying to get to the.
Yes, but I think a wonderful talk by the previous talk, and I saw one of the papers published in ophthalmology by Ferenc Kuhn, and I think anyway, whenever you're ready, I'll stop.
Can you see my screen?
You stop that previous video and close that PowerPoint, the previous PowerPoint.
I'm sorry, yeah.
And then you can open the new PowerPoint.
You stop sharing, then do that, and then you can share.
Yeah, can. And then use the same computer audio button.
I got somebody else's computer.
Yeah. Many presentations are open.
Okay, sorry, huh? I thought I have it.
Yeah.
You showed it in the trial.
Okay. Let me see. Can you see the video now?
Yes.
Okay, here we go.
Yes.
Sorry about that.
Trauma. My financial disclosure, none. I'm involved in many organizations and societies. South African eye care delivery might be a good reflection of the management of trauma care in Africa. All African countries have a variance of healthcare models. However, the fundamentals and the challenges are similar. We could use South African model as the basis for highlighting the challenges all over Africa, a short journey. But let's look at some realities of the world we all live in, and this should be taken into account. The following slides reflect population-related ratios. So let's look at national income. The national income is an important factor to determine the level of healthcare and eventually the ability of countries to deliver a comprehensive healthcare package. And this includes trauma care, which is probably at the bottom of the food chain. The violent death rate is not necessarily related to the national income level of a country, but the dominant factors include the efficacy of governments, management ability, corruption levels, and other factors. Accidental injury-related deaths. The data shows a shift towards India and China. All injury-related deaths. These all injuries is a good indication of the trauma incidents that we can expect in ophthalmology and any other part of medicine, of course. Blinding disease, on the other hand, is high in Africa, with the main causes with cataract, glaucoma, and diabetes. But the bottom line is physicians working. And the comparable doctor ratios per population is low in Africa. And this reality does affect on all aspects of healthcare delivery. So we look at a combination of physicians working, finances which are low, and management abilities which are not always ideal. South African healthcare system, as an example, we've got a population of 55 million, 80%, 45 million are helped by government and the state, 10 million by private sector. The level of care, the state, is a combination of first, second, and third world standards. Private sector, first world standards. And if we look at the financial aspects, we see that in the private sector, the cost is around about $1,000 per person per annum, compared to maybe the US, $6,500 or more. While in the public sector, they've got only $200 per person per annum. So they're massive financial constraints. Ophthalmologists per population in the private sector, 1 in 20,000, which is the same as Central Europe. While in the public sector, 1 in 800,000, which is nearly 1 in a million, which is very low. If we add the residents and those in training, 1 in 300,000. Facilities, surgical facilities, where ophthalmology services are delivered, are in general excellent in both sectors, in the state and in the private sector. Anterior, posterior segment work can be done when and if an ophthalmologist is available. Infrastructure compensates liberally for scarce results. Private sector, ophthalmologists are available practically everywhere. State sector facilities, you can see the facilities are actually in very good condition and excellent. The private sector, all the bells and whistles, lasers, and without an FDA in Africa, any new technology can be embraced and used as the doctor requires. Training and surgical skills, residents in South Africa into ophthalmology, which is very popular, need to have already experience before starting their training, maybe 100 or 200 cataract surgeries done already. During training, they exposed to surgical experience, anterior posterior segment on a daily basis. And thus we see that qualified ophthalmologists have mostly all the surgical skills to all subspecialty fields to manage trauma care effectively by an individual ophthalmologist as is needed. And residence training often consists a bit of see one, do one, teach one. Anesthetic support, not a problem at all. If you look at the monitor studies, giving you an estimate of the levels of care in South Africa, you see the upper blue line reflects the private sector in South Africa. These studies proved it about to be rated fourth in the world according to access, quality, and other factors. Although the total South African level is much lower because of the vast difference in the two systems. And that's why we see in South Africa, Teddy Epstein, involved in the earliest lens implant with Harold Ridley, was in South Africa, and he implanted some of the first lenses in the world. Early LASIK research, lots of it done in South Africa. The first heart transplant was done in Cape Town. No surprise. What's the incidence of trauma in South Africa? In our Professor Roux, in our state sector, did a study, and we found new major trauma admissions for surgery with 2.2% of normal clinic visits. And previous cases, about 6% of normal clinic visits, which is very high. Although in the private sector, which is like our first world setting in Europe, we'll see that new trauma cases will be 1.14%, and newer previous trauma cases 0.7%. Major injuries are very common, and this is the obvious diagnosis, and this might be the less obvious diagnosis with a small foreign body on the iris. But why do we need a way forward, a different way forward? We cannot continue like this. This is a patient of mine, very friendly man, security guard, had a difference with his friend across the road, was shot by a shotgun, lost his left eye, his right eye had decreased vision. The left eye totally destroyed. The right eye had 3 shotgun bullets perforated, 1 remaining in the globe. But the waiting time before surgery was 2 weeks. When we were given the opportunity, we could treat him. His only eye recovered very well, silicone oil and others. And today he's a happy man. But he was very lucky. Not all are that lucky. So, in summary, our dilemma, we have a dual system. It differentiates between the rich and the poor. The rich, first world medicine, the poor, first, second, third world level. On the positive side, the skills of surgeons are excellent. 100% of the doctor population. Facilities in private university hospitals are excellent, and provider doctors are available. Rural facilities are less available. On the negative side, the differentiation between training facilities and peripheral areas is a problem. Access to ophthalmologists is limited, and trauma care is most likely done by residents with limited direct supervision over weekends. After-hour service is only available in larger centers or next day surgery. So if you're in Africa, what can you do? You can hang around, wait and see in Cape Town, where everything is available, first world like never before. Or you can hang around and climb and see Kilimanjaro. And by the way, LASIK surgery is freely available in Kenya and many other African countries. You can go to Tanzania. Tanzania, to recently, had very few ophthalmologists. Currently, they have an ophthalmology society, like in nearly every country in Africa. Or you could come to Lesotho and do something really valuable. 3 operating beds in 1 theater with great surgeons doing great work.
1 minute left.
In Somalia, visiting Professor Stilting in 2007, this was his taxi service to his host. Here, Professor Stilting and Dr. Dalma are teaching ECI operations in 2007. Today, we have an ophthalmological society in Somalia, a very well-functioning system. Needs help, but well-functioning. Africa has realities, and we need solutions. And one of the realities, you don't overtake an African elephant. As you might see, this is what might happen. But who are these elephants in the room? African elephant, politicians, big business, governments, medical insurance, not only one, all of them. So the way forward for trauma management in Africa, the macro environment, generic country-related challenges must be addressed. And this can only be done by governments. The dual systems must be streamlined. The overwhelming workload must be addressed. The logistical obstructions
Time up.
eliminated by better referral systems. The microenvironment, ophthalmologists have a role to play. There must be awareness of the complexity of the management of trauma cases, and it must be done by the higher skilled professional, and the obstructions in the referral system must be addressed. And with these few words, I hope that you have a better insight in the realities of this wonderful, beloved continent of us, Africa. We need input. We need a lot of help. There's so much positive goodwill in Africa, and we hope that one day you will visit Cape Town and will visit the rest of Africa. Thank you.
Thank you. Thank you, Professor Talma. And I think, sorry for that, saying that you are being allotted 11 minutes. We wanted you. And as I told you yesterday, I think we are all keen to work with rural India, Africa, and South America. And anyway, we have enough time to discuss. And as I said, we want to create a Pan-Africa Ophthalmic Society. We are happy America has a ASOT, American Society for Ophthalmic Trauma. And we have none other than the main, what do you call the nucleus of the entire thing, my good friend, and glad to introduce Professor Ferenc Kuhn, who doesn't need introduction. He's going to talk on ophthalmic trauma, my journey, and it's actually the world's journey, because he's the man who's revolutionized, following Gerhard Dreister and Klaus Simon in the International Society of Ocular Trauma. I'm fortunately involved with him from the second International Society of Ocular Trauma, and I think he's such a medical surgeon operating in several countries even today. And I had the great opportunity of climbing Machu Picchu with Ferenc Kuhn. So Ferenc Kuhn, to you, to all of you.
Well, thank you very much. So, very briefly, my journey in ocular traumatology, and as you can see, I still work in a lot of places. So this allows me to look back from today to where I started. And that takes me back to 1977. That's where I started as a young resident, and we had a patient who came in with full vision and clear media with an intraocular foreign body. It was extracted by God, the chairman of the department, and the patient was awake. Success, the foreign body was extracted by using the external electromagnet, but the patient started screaming and said, "I cannot see." So again, we went from this to light perception vision due to a vitreous hemorrhage. And remember, this is in the era of no vitrectomy. So I could not understand why every colleague of mine considered this as a success when I didn't, and certainly the patient didn't, because eventually he lost the eye. So I gathered all my courage and strength and I went to God's office. And I asked him, "Sir, why are we happy when the patient is not?" He got up from behind his desk and screamed at me. He said, "Who are you to question what we have been doing for 100 years?" So with my tail between my legs, I went to the door. And I still remember when I grabbed the door handle, I said to myself, from now on, I will question everything, no matter who says it. So the first question back then was, of course, why are we happy when the patient is not? Why do we measure success by whether the foreign body has been removed or not instead of vision? And that takes me back to the early 90s when we had a trauma conference in China. And one of the speakers before me talked about 4,444 intraocular foreign body extractions. And my talk was also on foreign bodies. And I felt ashamed. How can my experience be compared to his? And when I saw that he had 99.9% success rate, I knew it was the same problem. Success measured by whether the foreign body has been extracted rather than by vision. So when we did an early study comparing patients who were treated by the external electromagnet versus vitrectomy and the intraocular magnet, you see that the results are much better because we did it in a controlled fashion. I also questioned why in trauma cases we are not putting emphasis on removing the posterior hyaloid. It is true that back then it was not visible, or certainly not easily visible, but in most cases you were able to see some sign that told you, yes, the foreign body is removed, and yes, the posterior hyaloid has been detached. Another question I had was this: what terms do we use in ocular traumatology? Here you can see an article, any full thickness disruption of the integrity of the globe is the description for ruptures. But then you read the article and it turns out, even though the title said rupture, it included not only rupture, but laceration and intraocular foreign body. So when you look at this injury, what kind of injury is this? Well, in the US, it was called penetrating. In Europe, it was called perforating. This is what led to the terminology system, where you speak the same language. Another question was, why don't we have a proper prognostic information in trauma? So you needed proper information, because in the literature before the ocular trauma score was developed, was things like good or poor prognosis, such as an intraocular foreign body. How do you determine that? What is the definition of good versus poor? And you can see here when I reviewed the literature that all these variables on the left in some articles were found to be important for prognosis. In other articles, it was not. The millimeter where the prognosis becomes worse varies from 3 to 12. The visual acuity, which would mean an unfavorable outcome measure, is going from hand motion to 630. So this is the reason why the ocular trauma score was born. Another question which Rupesh elegantly demonstrated was, do you do treatment or prevention? Because prevention obviously is better. So when I started to work with the United States Eye Injury Registry, we had 3 states there and no international participation, and the reporting was done on paper. When I finished as research director, we had 39 states and 16 countries of online reporting. And that ties us also to the International Society of Ocular Trauma. And I was involved in organizing every meeting since 2003. Another question was, why do we lose so many eyes to PVR? And here you can see the original case that gave me the idea to do prophylactic chorioretinectomy. You see an eye here with a melanoma, and you see the treatment, which was removing the choroid, the retina, and the tumor itself. And you ended up with a large area of no choroid or retina. And I expected a lot of these cases to go to PVR, but they didn't. So I started doing a prophylactic chorioretinectomy, a case of which you see here. The article was published in 2004, and 14 years later, we reported it in many different kinds of injuries, taking the expected 70% PVR rate down to 10. Another question is, how do we do decision-making in trauma? Counseling. This is a very important issue to discuss the case with the patient and make decisions together. And finally, training. It's very important. And I have three major criteria that I go by. The first is always do some planning. Don't just sit in the car and start driving, hoping that you will eventually get to your goal, but have a plan. And that means in surgery also you have control. Everything that happens inside the eye must happen because you wanted it to happen. And finally, always ask the question, why am I doing what I'm doing? And this is what I emphasize in all my books. So in summary, the most important thing is, again, to question what you are told. Don't believe what they tell you, but ask the question, is it really true? Does it really work? The why question is, to me, more important than the what, the how, and the when. It's not that they are not important, but you have to have a reason for everything, every decision that you make. Because progress, improving on the status quo, will come from the questioning. This is the same philosophy as the father of vitreoretinal surgery, Robert Mockemer, did when he said progress comes from doing the unconventional. But you also have to accept your limitations. Doing the unconventional does not always work. You will have failures, which you have to accept in general, but especially in ocular traumatology. But don't be discouraged by that and keep on asking the questions and keep on doing the right thing. Thank you very much.
Thank you, Ferenc. I was actually looking for some more, maybe I give you a few minutes by the time we discuss. I want some nice, interesting, fun videos, which always you show. I know in last part you showed it, but I think you want all of us to laugh because we're not meeting anybody. We are in the Zoom, but I think wonderful, as always, we learn a lot from you, Ferenc, and I think you should be called the father of ophthalmic trauma repairs now. And I'm sure you have taught all of us to question. And I think even Dr. Talma mentioned about residents doing it, which is what I learned from you and Dr. Klaas Hyman, that experienced surgeons should do their own repair. It's not that the juniors should not be encouraged. I'm sure a lot of young surgeons are there in the seeing all over the world. We want to encourage that you become experienced. And I think there are a lot of take-home lessons. So I want that of Professor Huayan and my other Paisan. You can start the discussions because you are co-chairs with me. And we have also Akshay and Ganga, Rupesh to add. I know we have exceeded, but Ganga said we will have a good discussion because it's the most important session of the entire trauma session. And that sees that I think we, during this COVID time, I think we have done a lot of education through various groups and various societies. And I think Asia Pacific is doing a lot of good job. So, Professor Paisan?
Well, I think may I ask Rupert for his presentation. I think it's very interesting and very important because you like to organize a kind of IGES, which is very important for the world, for the global ocular trauma. I'd like to know what is the stage of this IGATS project at the moment? What's your next move? Yeah.
Thank you, Prof. We have gathered the data for more than 1,000 patients and from different centers across the world. That includes Australia, that includes Malaysia, that includes India, and that includes USA as well, and Singapore, of course. With that, we have submitted a couple of papers for publication, and once this is validated, we have formed the data collection form in a way where the forms can be sent to all the centers across the world, and without doing it on the cloud, you can enter it in the real time in your clinic. So that can be both prospective as well as a retrospective data form, and we wanted to validate those data entry points. Now that's been done. With that, also we have included a schematics which can give trauma in a very different way, in something like a picture way. That also has been included in that form. So we want the global partners who are on this call, including the respected members from ASHOT, from Africa, Professor Talma, and of course it has been blessed by Professor Ferenkun already, that everyone to kind of start using this form, and then only we will be able to collect the data. So my talk was today mostly to encourage people to get on with the data collection as far as possible. Thank you.
Thank you.
That's great. Yeah.
So the next, I think, was Professor Graham Holder. So I have a question for you, Professor Graham. That many times the ocular trauma patients present with no perception of light, and many times may be associated with vitreous hemorrhage and retinal detachment. And sometimes the primary surgeon wants to do a VEP and a ERG. And what is the role of VEP and ERG in an eye with the vitreous hemorrhage and retinal detachment following trauma?
Premature. You need to do the primary surgery first to allow the eye to receive the light. If the retina if the eye is full of blood, then the eye is not going to get the signal that it needs. What you then, if you do the vitrectomy, you get rid of the blood, then you can see what's happening.
Good. So, Ferenc, I think I remember talking to you from Kashmir when bilateral injuries were there, and there was one was a post-retinal who had no perception. I communicated with you, and the idea was what to do, and he said, no other go. If you don't operate, the girl is going to be blind. You better operate by explaining. And you only thing you mentioned in the mail is counsel, and counsel. And that's what I did openly in the New York Times as well as in all the press in India. I said I'm operating an OPL, which is unconventional in non-trauma cases, but only in trauma we do that. And I quoted you and our friend in Fernando in Johns Hopkins, and I said we operate an OPL eyes only in following trauma. So any comments, Ferenc?
Oh, absolutely, absolutely. Both of your comments were excellent. ERG does have a role, VEP, so electrophysiology in general, does have a role, but you should never base your treatment decision at the initial stage on the findings. And now that you mentioned it, I did not put it in my talk, but I do remember it was in 1990 at an ORVO meeting where I presented cases where I did surgery for no light perception eyes. And I still remember when I said that, the room went so silent that you can hear a pin drop, which tells you a lot because it was heresy. But absolutely, you're correct. You should not enucleate an eye just because there is no light perception. There is no hope if you give it up, but you have to do it very early.
So you want to say something about Dr. Rabot Mazzoli's presentation? I think he's there. Dr. Mazzoli is here.
Yes, he is.
Can I just make a comment in relation to detachments? Because in a patient who's got silicon oil, you can't do an ERG and get meaningful data. The presence of silicon oil in the eye can abolish the ERG completely. So if you want to evaluate retinal function, you can do it secondary fashion by using a VEP, but you can't do an ERG to measure the function of the retina if there's silicon oil in the eye.
Thank you, Professor Graham. Is Dr. Huan, you want to comment something on Dr.
Yeah, thank you, Dr. Natarajan, and thank you all 5 speakers for giving us fantastic topics. And this session is very, very interesting. So I have a question for my good friend, Dr. Kuhn. So for non-light perception patients, you know, with the development and the technique for vitrectomy, most of the severe ocular trauma patients got better vision after vitrectomy surgery. So even for non-light perception patients. So Professor Kuhn, what's your idea or what's your suggestion for the criteria for non-light perception eye for keep the eye or enucleate the eye at the primary surgery? Thank you.
Yes, it's a very good question. Thank you. My basic philosophy is never enucleate an eye, regardless of the function, as long as it can be sutured together. So if you can make it an eyeball, do that primarily. And after that, you can sit down and discuss with the patient what the next steps are. I always discuss the possibility of a sympathetic ophthalmia, because even though the risk, as we heard before, is very low, but it is not zero. But if you give proper information to the patient, which means roughly 2/3 of these eyes, even if sympathetic ophthalmia does happen, will retain reading vision. I have not seen a single patient who would wanted me to do enucleation rather than reconstruction. So even if there is no light perception, I will, with the patient's agreement, consent, I will do a reconstructive attempt. It is possible that it will not work, but I will still not remove the eye, but keep it as close to the normal anatomy as possible.
Thank you, Ferenc. And I think I quote you and International Society of Ocular Trauma every day in some meetings or some referral patients, because somehow even today, sometimes I see primary enucleation happening or evisceration happening somewhere in the world, including India. I feel bad and I quote you. I'm happy I'm doing it for more than 3 decades. So now I go to Dr. Robert Mazzulli for a wonderful presentation and an excellent talk on damage control of ophthalmology. And I think I always quote the last chapter of Steve Charles from his book. And I think like this Ferenc Kuhn's talk and your talk, maybe all three, something like that has to be done for ocular trauma. Maybe we should have a book only on this sort of, what do you like to say? If you want to say something for the entire world now, like I know everybody has listened to your talk. What do you want to say as a take-home message? We all have taken photographs of your slide, and we have your recording with Dr. Gangadhar. I already told we should have your exclusive, each one's presentation separately in the YouTube. But apart from that, what do you like to say to the most young ophthalmologists in the world who are logged into the Zoom now or to the YouTube? Dr. Robert, you have to unmute.
Yes. Thank you very much for the opportunity, and this really has been a very stimulating conference that I think highlights the challenges that we all have in dealing with ocular trauma. And I think as Dr. Kuhn is talking about doing everything that we might be able to do to possibly save the eye, I think in terms of damage control, the fundamental step for me is that we have to do everything you have to have some rational system of approaching the eye and some goal, especially as you're faced in the excitement and the energy and the adrenaline of the moment. The question of where do you even start in dealing with an eye injury, especially if the eye injury is severe, that it affects the lid as well as the globe, that extends beyond the cornea onto the sclera, and potentially even involves the bony orbit and the orbital soft tissues. Not everybody is able to do all of that, to handle the totality of that injury alone. And I think at this point, with the amount of subspecialty expertise that is generally available, I'm not sure that we should all feel that we should be able to handle the totality of those sorts of injuries alone, as opposed to setting a foundation, being comfortable in setting a foundation for somebody who can come behind us and provide better fingers, better knowledge of that specific structure of the eye. So close the globe, as Dr. Kuhn recommends, achieve a watertight closure, align the anatomic landmarks accurately, and give somebody else something to work with.
Thank you. And the last question is Dr. Dan Talma for a wonderful concentration on Africa as a whole. And I think it's a dream because I'm part of the leadership development program along with the ICO and AO in the African Ophthalmic Council. And you have 52 countries. I know that was my dream to visit. I don't know when I will do. I visited some parts of Africa. But I think coming back to the management of ophthalmic trauma, so one is during this COVID time, I feel there's an opportunity to teach. I know it's not practical, but at least we can do online training and whatever way we can do a skill transfer. And I think we have experts like Dr. Pyson working on AI, Dr. Rupesh, Dr. Akshay Nair, Gangadhar, and then we have a lot of experts in the group. Can we do something to do online training for the entire Africa, rural India, and South America? I'm not saying that India has the best of best surgeons and also the best towns and the smallest village like Africa. So I think it's a need. And can we do something to do online training for anybody, anywhere, in any part of the world, particularly Africa and India?
Yes, thanks a lot for the opportunity. We really appreciate it. I think online training is always, especially in the areas where the need is the most, which is in our public sector, which is the areas where the younger ophthalmologists treat the major disease. And that is the big problem. So in our training programs, luckily we include trauma very highly, because first they learn the skills, even if it's a no light perception eye. And as we now want to add to what Ferenc has said, that we also tend to treat these patients even for the longer term because they're prone to accidents on the other eye. This is just, they're often accident-prone patients. So we try to preserve the eye in contrast what I was trained, and that is to do an evisceration quickly. And we don't do that at all. In terms of training, yes, absolutely, because in some countries, there are only a few ophthalmologists, and they do have an ophthalmological society. And I think bits and pieces, short bits, we have lots of webinars on glaucoma, on refractive surgery, but not very much on trauma. And I think one should do it maybe on an organized basis all around the world, because all the young doctors are seeking for advice, and the senior retinal surgeons are not that interested always, with all respect to trauma treatment, because it's a hassle factor, it's difficult, it's emotion. And I think that will be a wonderful program to set us somewhere a similar project. We like to help with it with great pleasure.
Sure, and I think my dream is to create an African Trauma Ophthalmic Society, because already ASOT is there, an American Society of Ophthalmic Trauma. We don't want to clash with America, so we want to have African Trauma Ophthalmic Society. So ATOS. So with that, I think
I can make a comment. Can I, with your permission, can I make a quick comment?
Okay.
Yes.
Yeah, very quickly. Now that we have ISOT president, and now we have Chinese Ocular Trauma Society president, we have a representative from APO, Professor Paisan also. We have executive and advisory board for ASOT there, and we have APOTS here, and I'm sure AIS can be represented by Professor Natarajan, and we have all the major societies here. Can we use this opportunity to kind of agree in principle to set up an MOU, to set up whether it is a data collection, whether it is a training, and let's set up a global consortium to address this giant problem. And that's what Professor Ganga has given the theme, to form a global work group. So maybe between us, we can set up a global work group where it can be just not only the data collection, but also looking at the training. And also, as Professor Majoli has said, damage control ophthalmology. So we have to look into an entire curriculum, be it setting up a subspecialty of trauma worldwide, be it setting up trauma units, be it setting up probably trauma hospital fellowships. So I think, can we take up at least a call in principle with all the big shots here on the board? What do you think, Dr. Ganga?
I think so.
Yes, could I?
Thumbs up for that.
Sure.
Can I?
Yes.
Could I add to that?
I think it's a wonderful session. I don't feel like concluding it, even though I'm the chair. So Dr. Ganga is sending me messages that he wants to do a
Let Dr. Talma speak, and then I will just close.
Okay.
I'd like to add that this year the WOC, World Ophthalmology Congress, was supposed to be in Cape Town. We had it as a virtual congress. And I think this can easily for Africa be coordinated even amongst them. We have lots of contact with them. And I think we can do it on that way for Africa at least. And they would love to have some project. And I think it's a good idea. Let's start it.
As I told yesterday, we have Dr. Sanush, your colleague, Dr. Sanushka Mudli, is signed up with the member of Asia Pacific. I also, on behalf of the Pretoria Eye Institute, I want to...
He's in our clinic, yeah.
Yeah, no, I want to request Gangadhar and Rupesh to take that Roma form at least as the first step to do a global survey, and the same thing to extend. And also, we all sign up for the global consortium, as you said, Rupesh. And I think if you make it up, and I think we have the president of ISOT here. So we'll do that. I think, as I said, I'm learning like a young student here with all the stalwarts. I think everything good has to end. So with a great difficulty, I'm going to put a zip for myself and giving the mic to Ganga. And I thank on behalf of Asia Pacific from my side, personally, to all my friends all the speakers.
Thank you. I know we are way over time, but I wanted to personally thank every single speaker on this special session because they went way overboard in terms of hard work they put in, their life's work. And I hope, like Rupesh mentioned, this is the beginning of a global conversation between the American Society, International Society, Asia Pacific Society, and Chinese Ophthalmic Trauma Society. So the COVID has brought us together, and I think we'll have some deliverables towards the end. And I think, thank you very much again. I'd formally hand over to Dr. Rekha Khandelwal, Dr. Rashman Gandhi, Dr. Prashop, and Dr. Rashman to the even more exciting aspect of our program, the Ophthalmic Trauma Quiz.
So before we go, can everybody come on the screen and have a thumbs up?
Yeah, thumbs up for the global consortium.
Sure, we'll do a screenshot.
So can you take a picture of this thing?
Take a picture.
Yes, done.
Okay.
Yes, done.
Thank you, Dr. Rekha. Sorry, we ate up your time, but I think I always
is there.
Karan and Dr. everybody. Thank you. Thanks a lot.
Thanks.
Thank you, everybody.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Want to send me the photo?
Back for the quiz, please. Yeah.
Send a photo to me by email.
I welcome you all to the last session of APOTS 2020, and that is full of excitement and tickle your gray cells. I thank Dr. Natarajan, Dr. Ganga, Dr. Rupesh for including this ophthalmic trauma quiz in this conference, which will be online on myquiz.org platform, and it will be for 30 minutes. It is a non-stop quiz that is like a workout. And we have two separate quiz rooms based on academic qualifications. So enter your respective quiz room as per your current academic qualifications. We have a Ronaldo team and we have a Messi team. And if you are currently a medical student or doing residency, please enter Messi room with a code. And if you have a degree or diploma, then enter Ronaldo team, which is shared on the WhatsApp group. So please enter your respective quiz room with the code, which is already shared. And in case you enter a wrong room, so what happens? You may not be entitled for the prizes. So beware and please enter your respective. There are very exciting prizes in both the categories. We have 3 prizes. So enter your room with the hall ticket. The quiz will have 40 questions and there are 8 rounds. After every round, there is a non-academic break question. So that will tell you that the round is going to change, and it starts from anterior pole to posterior segment, anterior segment, adnexa, everything, whatever we covered in last 2 days, management, diagnostics, and the last one is a rapid fire round. So one thing is important, that once you select a answer, you cannot change it. So you have to select it very quickly, because you can have bonus point, but you have to select it correctly. There are also some video questions, and you have to press a play button to view the media player. So just log into your code, and then we can enter the quiz room. We have this time, we have 181 registrations, and still we are getting questions on the group that we want to enter. So we are opening it for 10. We opened it for last 10 minutes to let people enter it. And there are 7 countries who are participating already in the quiz. They are Singapore, Malaysia, Bangladesh, Indonesia, Nepal, India, and Kuwait. So we have residents, we have consultants, we have fellows across the globe. And I wish all the best. And we have team members. Dr. Rashmin is here. Dr. Rupesh is here. Prashov is here. Dr. Rajiv Raman. We are the quiz team who have created this. And I hope you all enjoy this. And after the quiz is over, there are 2 things which you have to do. Top 3 players have to log into Zoom and identify themselves again for the prizes. And also there is a short link for the feedback, and that you have to enter and press it. So without wasting time, I declare this quiz open, and please enter your quiz rooms. Rashmin?
Dr. Rekha, you would like to show that slide of that thing? You wanted to show it?
I will.
And the rules once again.
Rules one second, please.
Slide.
Yes.
Let me remind the participants that timing is important, not just the correct answers. You have to answer fast. You get bonus points for answering fast.
Dr. Rekha, make it bigger screen.
Yes.
Yes. We don't want to disclose the prizes now.
Yeah. Yes. So you should have a good internet connectivity. Laptop is preferable, and then join with a code. Then you can see number of participants who are competing with you. There are trainee rooms and also non-trainee rooms, those who have degree already. It's a single correct response type of MCQs, and selected response cannot be changed once selected. Answer fast to earn bonus points. There are no negative markings. It's automated marking, and there are 8 rounds from back to basics, trauma terminology, and then anterior segment, posterior segment, adnexa, diagnostics. There are case-based type of questions. There are video-based questions. There are photograph-based questions, CT, MRIs kind of investigations. And then there are rapid fire, which have less time. So the time is variable depending upon the difficulty of the question. And there are break questions after each round, which carry no points. So you can do it wrong also. But do not forget to fill up a short feedback form. The link will be shared on the WhatsApp, and it is already once shared with you all. Yes, Rupesh?
Yeah.
Yeah. I think we are ready to go ahead with the quiz.
Yeah.
Let's do it. Let's roll it, ma'am.
Let's roll it. Let's see who is there. What do you think, Dr. Rasmin? Who will be the winner? Do you think? Any bets?
Well, let's see first who all are competing.
Is the betting allowed on the APOTS platform?
Yeah, only thing is one of the session in charge, he has asked whether he can participate.
The session in charge, how much he's giving? Yeah, let's figure out. Let's fix him.
So I'm starting again. I'm sharing the screen now.
Yeah, you can, please.
Yeah. The panelists, be ready. We'll be shooting questions to you.
Yeah. So that nobody goes to sleep during the quiz.
Yeah. And this is because Ferenkun likes to play football. I know. I was in Rome and he was out for his football match.
So this is our messy room or a trainee room. And I'm starting it. And this is our second room. That is Ronaldo room. And I've started that.
Do you know I was a football captain in Madras Medical College?
Is it?
Really?
This is the first question, which is
okay. Here we go.
All right. So we started the quiz on my quiz. A lot of people are already answering there. And this is which room, ma'am? What you are sharing right now is a trainee room, right?
This is the consultant. The Ronaldo group.
Ronaldo. All right.
Yeah.
Okay.
Oh, they cannot answer this thing. Dr. Ganga has given a nice talk on the oculoplasty, but apparently it looks like no.
Sometimes consultants forget the basics.
Yeah,
It's the basics wrong.
basics wrong, consultant. Then we need to go for a reappraisal system.
Well, that's why we train the youngsters. They can remember the basics. We can just move on and take the credit for good work.
Ganga, that's why I prefer
Webinar training.
Dr. Natarajan, this question is for you.
No, that's why I prefer to chair the meeting.
Okay, so this is
My goodness.
retinal dialysis.
It's not good, huh? Consultants are not able to remember their basics.
Don't embarrass us. Go to the residence screen, please.
No. This will reinforce.
Don't show my name, especially.
This will reinforce Professor Talma's theory that need training, right, Professor Talma?
Yeah.
People
We
need
need
training.
training on the internet. This is a webinar, the first one.
Internet.
I was brought up on see one, do one, teach many.
Yeah.
I did see one first and I started doing it, like parents did.
Who has given the talk on cranial nerve palsy? Someone has given a talk on cranial nerve palsy yesterday.
5%.
Question.
This is a break question.
Everybody can relax.
I'm going to make him an offer he can't refuse.
Yeah.
Who is supposed to answer? Is this for the panelist?
Everybody can answer.
Anybody can answer this.
So here is your offer, Rupesh.
My offer, this one I'm supposed to answer.
Yeah.
I will say A, B, C, D, A, B, C, D. Oh, I was just about to say. How is it? We are done with round one?
Yeah.
Round one is over.
Round one is done.
Round
Where
2 has
basic
started.
work
This is on trauma terminology.
Yes.
The round 2 is on trauma terminology. Okay. We are still in the consultant room?
Yeah,
This is the trainee room. You can just see the top. It's written messy, trainee room. Okay. Who is still with us?
Yeah. Which of the following?
100 answers. Could you see, Rupesh? In that?
We still have a good, not bad, I would say. 45%.
They need a book by Professor Perrington to read all these things, right?
Not so much, sure.
45% got it right. And trainees.
Not bad at all.
Not bad.
Yeah.
I'd say very good, not bad. Very good is a positive word.
Excellent.
Especially Mr. Kuhn is watching and listening.
This is again Dr. Kuhn's question.
Kuhn's baby.
Kuhn's baby, rather. Yeah. Globe rupture. He was very particular. One of my paper got rejected because I mixed up the word of rupture and laceration and open globe.
Or did you put Birmingham, UK?
I was looking for him in UK.
That you used to do even during the
Yes,
Viva.
You know that. Don't say that.
You may have a question on that. So
Oops.
let's not discuss further.
Okay, after the first 5 questions, I have given up. So I'm back here.
He was the one who wanted to participate.
Who was the one given up?
Akshay Nayak.
Akshay Nayak is given up. Huh?
The only oculoplasty question I got right, and after that,
Try this then. Try this. Game of Thrones question.
Oh, I have not watched 1 second of 1 hour
Professor
of
Graham
one
Older will
episode of one
definitely say
season
this.
of Game of Thrones.
Answer this.
I haven't seen any of these movies.
Exactly. Apart from the title, I know nothing.
Yeah.
And the title music.
Ferenc Keen wasn't the actor, I see.
These people answering wrong also. They don't watch movie. They don't read Perrington book. Then what do they do?
Dr. Talma, please bear with us. These guys can be a little irreverent at times.
I'd say they're a bit busy. They're very busy. Falling state description.
IOS.
Silicon 3-piece.
IOL. IOL is what? Intraocular lens? Is it correct?
Yeah.
Oil and IOL.
They must be sponsored by some pharma company. They will say which pharma company is lens nowadays, right?
So people do wrong because they don't read accept.
That's a very
This is
important
a very
thing.
unfair question for an oculoplastic surgeon. He doesn't know anything inside the eye.
When have you done the last ocular cataract?
I've cost them, yeah.
May have scleral fixation, that's right.
Oh, this is again picture copyright.
A very interesting question. Most people will be knowing the answer, but not the name of the suturing technique.
I try many times in practical, in real life, it is very difficult.
Yeah.
Let's see how many answer this.
No, there's no option of glue, is it? Or scleral lens?
No, you have to answer the. Oh wow, still 22% have got it right. Yeah, that's not bad.
Akin method.
The maximum people answered Rutherford's method of corneal suturing. Does anybody know what that is?
No,
I just made it up. It's a fictional method.
I don't know what that one is.
Only Professor Kuhn can educate on us this thing.
No such thing as Rutherford.
It should be here.
There's no such thing as Rutherford's. Huh?
The video question.
Repair is the most incorrect step. Method of
So this is the consultant's link code.
no.
Yeah, this is Ronaldo.
Is it pilocarpanized eye? Pilocarpin.
Iris abscission. Iris abscission. Good.
Most incorrect step.
The video is repeated.
That's very clear. Yeah. Iris.
27% have got it right. Place for manual vitrectomy nowadays when we have automated instruments.
Yes.
Yeah.
Let's look at the leaders for a second. The Dr. Riddhi, I think, is leading right now.
Yeah.
Followed by Dr. Shreyas.
But everyone is 60 only. How can you decide
They're
then?
all than 60. How does that work? Yeah.
They take the timings into consideration. Yeah.
How are you going to do with the tiebreaker, like the final? It will not happen like England New Zealand cricket match final.
Usually it happens like it's a photo finish at the end.
Super over.
Shield topical steroid.
Be ready for 5 prizes, I think. The leaderboard is showing 5.
All 5 on tied on 70.
All 70.
The timing that's going to decide. I mean,
Yeah, the last question. On the last question.
yeah.
Even the tiebreaker, right? The
that
fastest
is-
finger first, last ones.
Yeah, I think the youngsters who are watching Professor Talma, they should learn from him. He's still so learning everything. I think this is a real inspiration for all of us. We should take from Professor Talma.
This is the most correct statement. That is the question.
Most correct. That can be. Oh, that's a bit
And
controversial.
most of them have answered it correctly. Slightly tricky question.
And this is very patient specific.
This is another break question.
For all the cosmologists out there. What do you think this is?
Supernova.
Eye of God. Any guesses?
Oh, wow.
Hello,
I
Christmas.
think I've seen this recently somewhere. It is a posterior capsule rupture.
Helix. Nebula. This looks like Synechia and massive Synechia with a red examination light.
This is probably millions of light years away from any human eye.
What is the incorrect statement for traumatic? Or
Incorrect statement, traumatic macular. Amar, you are there?
LM peeling is a neurosurgical path.
I'm there quietly watching.
Amar, you have to answer this correctly. Let's see whether you can answer before them.
Yeah, well, it's a retina question, as you know.
See, retina question, you have to cataract. You not kept the topic of traumatic macular hole, though. That's unfair for the student. If you had kept it, then they would have given the answer.
But it's 1 and 3. 20 odd more percent.
Picture question. I think you have to look at the picture carefully. Guess what the right answer.
This looks like to a uveitis person, a CMV retinitis.
Yeah.
Excellent quiz. Very well made questions. That's amazing.
Thanks, Amar.
I would have.
I think this is a lot of efforts by
Absolutely, it is.
Rekha
Yeah.
and Praso.
Okay, Rekha has worked a lot for it.
I'm working on it for quite some time.
Yes, it's a lot of hard work.
Oh, amazing.
What is this?
This is a slit lamp examination picture.
Rajiv is sitting quiet. Let's see. What is Rajiv thinking?
What is the most likely decision?
Slit lamp picture. All the glaucoma specialists.
Glaucoma specialist. Huh? So we missed the talk on traumatic glaucoma. Then you should know it's unfair for students to get a question on glaucoma. There was no talk on the glaucoma yesterday. This is Dr. Mohan Rajan.
You can consider giving only half points to this.
Yeah, but we discuss a lot on hyphema.
Yeah. Yeah.
Hyphema
I think hyphema was a topic.
Hyphema was a topic.
Hyphema is an injury, yeah. What's related to the insurance then?
This is the interesting surgery.
Again, note the except.
And up to accept.
The except is what gets you most of.
Akshay, this is beyond your subspecialty.
And shaking hands is not good.
It's not a good thing with the forehead.
It's the time of Corona, you can't shake hands. So,
but with a new
that is
chandelier, one can much easier remove it with 2 hands, I must say. Not handshake. But the chandelier lights are wonderful in your vitrectomies.
So which round are we in? And can we look at the scoreboard? How are the people doing?
yeah, scoreboard is on the right side. Dr. Shreyas is leading here. 110.
Yeah. And
just inched ahead. And in the consultants group, Soham Pal is leading. Pal or Pai? Pal, I think.
That is actually me in a different name.
Metal.
Yes, sir. Is it allowed? You cannot put the
Both categories.
That's a big chance.
You put up your proxy somewhere, huh?
Yes, both
your secret name.
Who is he?
This is Tom Cruise. It's written there in the quiz.
This is written there.
You just have to guess which movie he's not in.
I thought.
Again, except.
Yeah.
Yesterday I said
that I know at least. That I know.
You said for Mohan Rajan. This is not Tom Cruise.
Not bad.
Not bad.
Yeah, that's a good thing.
Anybody knows who acted in The Aviator? Lead role?
At least it was not me.
7.6.
I hope this is not Tom Cruise. This must
be in 7 movies. He still gets Cruise.
The most appropriate initial.
We have come to round 5 now.
How many total rounds, Praso?
8 rounds, including one rapid fire.
This is round 5?
Yes, this is round 5.
Round 5.
And we reached fibroplasty and
the quiz attendees is getting tense. They are having enough moral support or not?
Both are on 120.
120.
Yeah.
And Ravija
Amazing.
Yes.
Dr.
Ravija
Ravija
is
is
who? Dr. Asmin, your student, Ravija?
There was one Ravija in SN. I don't know whether she's participating. She was a
But that time you left SN that time, right?
No.
All of the following tricks. Yeah.
trouble is you have to look at the picture, you have to identify what the diagnosis is, and then you have to notice the accept and click the correct answer all
Spelling.
at the earliest.
Alone should be surgical.
Pretty tough question. Still, most of them have got it right.
No, upper candidature.
Radiographs.
The image is an essential component of the plan.
Now, can you scroll down a little so that the other options
You're
are
out of focus.
reconstruction?
Fracture reconstruction. Terror, palate. Yeah.
High number have answered it correctly.
I thought it was patella bone. I would have gotten it wrong.
Repairs total eyelid defect from trauma. What is preferred use? Disembodied.
What do you do with the tissue that's disembodied?
Disembodied tissue.
There is no true tissue loss. Yesterday Suzanne told very clearly.
Implantation, even if tissue.
I was emphasized.
Just never, rarely lost.
Doctor,
that was a phrase, I think.
Dr. Ganga used to tell us also when he used to teach us there.
Yeah, implantation, it's like an iris.
Unless a human or a dog has bitten it away. Which has happened,
Human bites.
It's not like general surgeons. I remove it all, which is part of optic nerves and kitchen.
Traumatic optic neuropathy. This one, optic canal?
Maybe not.
Maybe not.
Maybe not. Just trying to mislead. This one, Dr. Asmin has to
The
answer.
participants are advised
not to listen.
Exercise their discretion, not to go by misleading. In this case, he was right.
I was
right.
He was right.
One question. Is there any prize for me?
Yes.
Yeah.
Again, participants are advised that quizmasters may be misleading.
Next conference.
Very nice. This is amazing work done with the questions.
Yes. Thank you, Professor.
Fantastic.
Thank
That's
you,
a hard work. Yes, this is very nice.
Wow, this is
the most popular piece of topic.
Have you had your dinner now so far? The Singaporean team. Navneet? So they're not having dinner, huh?
My favorite is mushroom.
Onions, mushroom, cheese. With us,
Mushrooms and
it's
extra
cheese, but I'm not sure everyone else will do it.
Yeah, thanks of pepperoni.
Pepperoni.
Popular pizza topping in the world.
Extra cheese was a catch.
Cheese was out in South Africa. Not in Italy.
Here also we can put in that cleft some cheese. China, why not? We can put a glue or something like that in the sewer.
Yes. Inject.
Someone given a very nice talk yesterday on hypotony. Actually, that was a fantastic talk. Victor.
Disruption.
Where is Victor now?
Longitudinal.
So which ring of there are 7 rings, right?
Yeah, we have a question on that also. So we can discuss that. We can't discuss that either.
Can't discuss that also. Sure.
I think we have a question on that. No, I don't think. No, we don't have a question.
No, we don't have.
We don't have a question on that.
Yeah,
it was a clip. It was a clip. Actually, I got confused with it. It was a clip that we had, not a question.
Operation.
One of the 7 rings. Sure.
Retrobulbar
question.
Solid arrow is what you have to see, not the hollow arrow. The solid arrow.
Solid arrow.
Like,
Huh?
yeah, it's like
that
for
one.
comparison, you can look at the hollow arrow.
Okay, that's interesting.
So that is an optic nerve compression of some sort. Yeah.
Very good. Ravija, Soumya Narayan. So they are the kind of leading for. There is not much of change happening. The leader is leading.
The leader is Ravija, but not by a long shot. It's,
Yeah. They're all within 160 to 160.
Very close.
Just a matter of one question, and we have rapid fire. So
rapid fire can change everything, right?
Everything, yeah, can change everything.
Any idea how many people have given up so far?
Yeah.
Now, software, I don't think has a capacity to do that. But I know a consultant who gave up, a coordinator.
Don't mention my name, please.
One quiz master, one never turned up after looking at the difficulty of the quiz. I find it very difficult to answer.
So nice to see the neck-to-neck race. Yeah.
Yeah, actually very good.
Any of the top 5 can win it.
And
there could be more, and you can see only the top.
No. Ultrasound chemist.
The Shreyas has been leading for quite some time in the training room.
But all 3 scores are equal, right, so far?
Yes.
So why
This
is one?
two, the second and third looks like from.
It's the timing, I guess. The faster you answer, you go.
All right.
I think.
Thank you.
That's why you get that bonus point also if you answer fast.
Yeah.
Do cataract surgeons also get rewarded that way? I'm just
I must have status. Restrictive motility disorder. 3 weeks.
Then, bit of basics. Something which you learn in post-graduation.
This one I can answer definitely.
Yeah, this at least I can also answer.
Yeah, at least I can answer. So kind of people.
Don't force yourself.
Yeah.
Why I was majority.
Dr. Tama, if you have job opportunities now, you know who to pick on.
Yeah, I see. You see, we've got a shortage in South Africa.
Yeah.
But it's going to be in the rural areas, unfortunately.
No, Rashmin Gandhi already has several outreach projects in Africa, Dr. Tama.
Yeah.
Yeah, I know. Yeah, we see a lot of stuff happening.
This is a brain racker. It's a puzzle.
Dr. Agarwal is a lot in Africa.
Choose the machine comes out of the given alternative.
Yes, you can answer.
Why should he answer?
Why? Why? Why is the question?
Why should I answer? Why should I?
All this kind of.
Anesthesia should be used. Yeah.
Akshay is back. Akshay had the pizza. That I was thinking, why is the one pie of the pizza missing, Akshay?
I am on keto, so no carbs. So it wasn't me.
What is the topping you had?
Management of trauma. Is that the management of trauma system?
So, yeah, we are in the 7th round. I think we have one more round, right, ma'am?
That rapid fire.
Yes.
After this round.
After this round. But this is management round?
Yes.
This is the management round.
Management. Wonderful. Rajiv. Rabia. Ravija.
We have Dr. Unia also watching quietly. Dr. Unia, you have any comments?
Yes, I think it's very interesting, Rupesh. I enjoyed this quiz.
So what do you think this is? The reason I called you is for answering this.
Oh, yeah?
When have you touched the gonioscopy last time?
Oh. Did you want to answer the question?
No. Thanks for your support, Dr. Unia. So kind of you.
Yeah.
And I can see Dr. Geeta also there.
Yes, I hope the Indonesian residents
Can win the
doing
prize.
this quiz is
And the prize.
Well, they can win the prize, but you have to talk to me separately. Then we can set up something.
exactly your base.
Yeah, but very good. Thanks to you and Dr. Geeta, Lisa, and all your colleagues for wonderful talk.
Okay. Yeah, thank you also. I think I would like to say congratulations for you, Rupesh, Dr. Ganga, and Prof. Natarajan.
Talk to me.
No, thank you. Would not have been possible without your support.
This is just the teaser, the appetizer for our Bali meeting.
Yes.
Yeah.
Bali will do it live.
So we're keeping the standards quite low, you know.
Yes.
Imagine, Dr. Yunia, what we would have been doing now for the dinner and all, nice dinner in Bali.
Yeah.
Yes.
Now we can do.
And Dr. Natarajan would have been dancing this time.
Yes, I hope in the next years. Yeah.
No, Rupesh?
Yes, sir, you would have been dancing by this time. The conference over and then.
I'm missing all that.
Yeah.
I remember Dr. Prof. Natarajan, you are the king of dance.
You know the meaning of Nataraja? Gangadhar?
Yeah, that's exactly what it means.
So that was my ragging question to all the first years when they joined MBBS. What are the meaning?
When you were being ragged or when you were ragging them?
I was when I was ragging, when I was getting ragged, my principal was Madhivanan's father. So everybody will say, "Arey, tell your name and don't tell the principal's name." They used to tell. His name was Amniotic.
Natarajan, yes.
Sympathetic ophthalmia. Let's see what is Professor Peter Michalski teaching has done. It's not there. Michalski?
And it's the incorrect statement that you have to pick out.
Maybe I just like to comment regarding the quiz. Yeah, I know I have presbyopia, but I think the fonts are very small.
You can use the low vision aids.
Yeah, even with my
it's chandelier illumination.
it's either presbyopia or dry eyes, maybe. Yeah, from looking too much into the screen.
You can take a photograph with a mobile and then enlarge and see.
We have a song question here. We have to listen to the song.
Is there an audio there? Shakira's song?
Meanwhile, there is a change in the leaderboard. Now Stephen has
come up. Yeah.
Oh, wow. Who is this Stephen now? Proxy for?
Now we have come to rapid fire. It's going to be
things will change.
Sudden death now.
Pass down. With 7 seconds answer.
Rapid fire is started? Started? Rapid fire? Do they get a negative mark in rapid fire?
No, there are no negative marks.
No negative.
You are very kind to candidates.
By the way, the candidates don't see the Zoom. They have a separate screen in which they can. It is enlarged. It's not small.
If it is on Zoom, it's smaller. They can enlarge it.
Which dress is stopping?
Ravija, I think, has taken the lead here. Good.
Injury is limited to.
Shreyas is back on top.
So Shreyas is back on top, but still same, sharing the lead with Stephen.
Yeah.
Shreyas is not going to give.
It's a fast track question.
Oh, they are still doing 260, 260. We have to have a kind of a super over.
Last question is the super over. The last question is the super over.
Okay, let's see. Because we don't have extra price.
Imagine what Stephen is going through now.
That's nice controversial.
Session on this. Yeah.
Disagree.
That's why they should attend these webinars.
Yeah.
Contraindication.
I think we are at the penultimate question.
Agree.
And this is a
This I can answer.
This one also they get prize. This one is also they get a prize.
No, no.
Answer D, man. Rashmin.
Special prize.
Who is that? Amar?
Yes, special prize for that.
Hey, this is fun. This is wonderful. This is great.
Oh, wow.
Well, I request all the winners to just contact me over personal message on WhatsApp.
Okay.
So I request the other quizmasters to continue. I'll just sort out the other things.
Then, okay. Do we move back to Zoom?
Is the winning prize? Is the winning prize a free conference in Bali?
You can announce the prize.
Okay. Thank you very much for the wonderful quiz, Dr. Rekha Madam. And really appreciate it. The quiz was all prepared by Dr. Rekha Madam. Thank you very much. And really appreciate all the efforts that you put in. It was well supported.
Dr. Rekha, I couldn't take the screenshot. Could you show the winners again, or just send me a WhatsApp?
Okay. So,
I'm sharing it.
Yeah, just share it once again.
Share the screen. Here we go. We have two teams.
Just a moment. The other group.
So, madam, you can share about the names. I will then share
the other group. The other group.
I will then share the prices.
I got this one, ma'am. The other group.
Yes.
No, just the other tab on the mic.
Can you see now?
Still the same thing.
Oh, shit.
You're sharing all right, but screen is stuck, I think.
Ma'am, you have to stop share and then again reshare.
Reshare.
Madam, first stop share. Go to the correct one and just tell the names. I will then share the names.
Yeah, fine. I got it.
Also, we have the details of the winners.
No, I'm getting it, sir. I'm getting it.
Why don't you discuss some interesting questions from your quiz or controversial answers?
Yeah.
Now that it's over.
No, that's very important. So, Dr. Rekha, thanks for wonderful quiz.
Holder, all the big...
Professor Dalma, thanks for being with us and all the young residents and everyone. So, do you have any words about how the quiz was there and then how we could have improved, and any other feedback from you?
Yeah, I think the quiz is fantastic. I think one could give it a bit longer time because some of the things are a bit controversial. Okay. And for the presbyopes, that might be just a thing.
You don't come under that category, Dr. Talma.
Not yet altogether. Just a thought on that, but it's something I think we're going to use. It's fantastic.
Professor Holder, Professor Graham Holder, do you have any comments about you were watching silently, and then you have anything particularly to add? What we could have done better for the quiz?
No, I think overall you've done a great job.
Thank you, Professor.
Very successful meeting, very well organized. And I think whilst you may have upset a few people with the interruption saying 1 minute to go, time is up, the only way to run a successful meeting is to have a chairman who is strong enough to tell people that it's time to stop. And the fact that you've done that for everybody is perfect. It doesn't matter whether you're a professor or a junior, you still got told to shut up when it was time to shut up.
Yeah.
Excellent.
Sometimes they do not realize they are saying on a video also. Videos were also asked to stop.
Parents Cone was asked to get out, and you know what he did, right? He changed the world. You're right. You're absolutely right. May I invite now all the chairs, co-chairs, speakers, especially our global experts who have given all these talks to come online so that we can have a nice discussion for the next whatever time, half an hour, 25 minutes we have allotted. Assuming it's still reasonable time for most of you. Talma, what time is it in Pretoria now? You're muted, I think, yeah.
About 3 o'clock in the afternoon. Sorry, I was on mute.
Well, thank you very much.
So,
I hope we didn't spoil your day.
Yeah, I must say thank you very much to all the organizers. This was amazing effort and a lot of work done. And I really think we should do one thing, and that's to put trauma higher on the agenda, because in our country, and I'm sure elsewhere, those are the patients who always come second. And they often, no one likes to treat them. It's trauma, it's emotion, and one must really give it status, even in a insurance, medical insurance basis, maybe have a modifier to pay people better, to treat them better. It's in those private sector countries, because you never treated properly, paid properly for these patients.
That's the reason why you may have noticed that we had so many trauma sessions, thanks to Professor Natarajan and the entire organizing team. We wanted to get the message across that it's very common. Every specialist and non-specialist ophthalmologists and even non-ophthalmologists encounter it. We thought it should be given, and we lobbied ICO. We managed to get a trauma section for the first time in the history of ICO, I'd rather say. And we are hoping that eventually the American Academy, the European Society, Asia Pacific Society eventually will have a separate category for submission for abstracts, instruction courses only on trauma. We've been doing these courses now around the world and in Asia Pacific for several years. Dr. Natarajan, you want to say something?
Yeah. So actually, even during the vitreoretinal symposiums, webinars from March 27, every case presentation was a vitrectomy for ocular trauma. So I didn't realize it. So this time, I think the Berlucci retina program cinema, they said, no, we want you to talk on diabetic retinopathy. So I'm happy out of maybe how many webinars I did. I think main was ocular trauma, because I think my passion for ocular trauma is there for day one, right from my residency days. So I think I think one important which I want to tell is we are all improving the skills and managing repair, but I think we also equally have to do something to prevent ophthalmic trauma, right from cracker injury advocacy to public burning of something, or even these pellet injuries, rubber bullet injuries in Chile, America, and maybe the Middle East. So we have to do something as an advocacy, and I think we have lots to do. Like Robert first said, lots of homework to be done by Ganga actually. And back to you.
Annette is leading that effort, and she's going to really take us globally. Do we want to continue some discussion, Rupesh, while you tally the prizes? Shall we have?
Yeah, absolutely.
So, Annette, if you're there for the first session, do you want to field some questions or post some questions or give some expert comments on your session while we wait for the results of the quiz?
Sure. So, I mean, for our session, I think Daniel is still here with us as well. I mean, it was a really great opportunity to have allied health people here, and for me, the opportunity to talk about the role that they have, but also recognizing, you know, how they can play a role in prevention and management and final visual outcomes as well. I mean, I think we need to really start working together, and I think across these platforms, this really provides a great opportunity where we can do that a bit more. I mean, Ganga and Rupesh and I have started talking about different resources that will be available for ophthalmologists and optometrists and orthoptists, whomever, who can promote eye injury prevention. I think all of these things we can all all play a role in helping to do that. Daniel, you had some really good points in the session. Did you want to add anything else to highlight from our session earlier?
Yeah, I think first and foremost, Dr. Ganga, Dr. Agarwal, and Prof. Natarajan, thanks for having us, the allied health colleagues and speakers. I think what I've learned is that there are actually hidden gems as we discuss the topics today. And I think moving forward, it would be feasible to understand what is available, what are the gaps in services, and possibly in future to possibly design and build capacity and capability across the optometry and allied health professions as we develop and advance in the area of trauma management.
Right. I think as much as we think the world is round, our aim is to flatten the world, and there are centers of excellence which have the full length, breadth, and height of depth of services, and centers which are resource limited. And sometimes even the value of, like what you said about good refraction, good ancillary procedures, good ocularis, orthoptists is very, very important. And that's where the collaboration now comes within Asia Pacific. Singapore, Malaysia, Indonesia, Vietnam, Cambodia, there's so many Asia Pacific nations. We'll start networking each other and raise each other's standards so that we really deliver the best that we can, not just stop with the best surgery, best CT scan, best MRI, but go beyond that and totally rehabilitate the patient here.
I think thanks once again, Annette and Daniel, for taking, and that was a very interesting session. So maybe something if I can suggest on behalf of APOTS is the prevention and education, as we have been speaking about advocacy, is something how we can formalize a bit more, particularly let's say if it's the glasses, what kind of high quality glasses and glasses is the prevention, and on the advocacy. So I think we can pick up certain things, and as APOTS, we are definitely very happy to welcome you, and we can have that platform, and definitely the platform of ISOT and all, and come up with a very tangible kind of a very clear-cut guidelines how we can all work together, and probably set up certain kind of guidelines, and which can be, we can pilot it at probably 1 or 2 cities or countries, and then probably take it forward and show it to the globe how it is. Because now, if you see, the intravitreal injections have been given by the allied health and all, we all do know that very well. So how we can kind of have that allied health expertise in trauma management, so we can figure out, and probably the level of triage, level of filtering, which are more severe, more simple trauma, something we have to kind of probably set up some kind of guidelines. So let's take it forward from the session what you have, and then see how we can kind of deliver, okay, besides the session. And then we have expertise of Professor Talma there, we have Bob Mazzoli there, and we have, of course, above all, everyone, Ferenkun there to kind of guide us. Besides myself, Dr. Ganga and Dr. Natarajan are always there with all of you. So I think we can we need to put up some structure. Yeah.
Amirawan, thanks a lot for leading the retina session. Would you like to make some questions, comments, address any controversies from your session?
Yeah, thanks, Dr. Ganga. I think it was quite a good session. There were a variety of the topics related to the retina. We talked about traumatic macular holes, dealing with projectile injuries, and especially the interesting was heterogenic ocular trauma, which we always forget that when we are doing surgery, we can induce the trauma. And that can also put impact. If we don't manage them properly, they can lead to poor visual outcome. So I think it was quite interesting and very good contribution from all speakers. So I think it went very well.
No, thanks, Amar. And any particular question which we were not able to answer, probably?
I think the questions wise, few questions were asked from the audience. I think one I asked to Dr. Geeta Lisa already. Other thing was about sympathetic ophthalmitis, because that's again very important. And as we were talking about early evisceration, or we need to repair the eye, that's very important that you have to judge. And if you look at like no perception of light, I think it's always better to do the globe repair first thing, and maybe that will help the patient to decide either they want to go for early evisceration or they want to keep the eye. Because if you look, like if I look at my practice, there are patients in which they had globe repair is a blind eye, late developed ophthalmitis. So I think it's really important to discuss with the patients at the time when you're managing them initially, instead of later once they come back to you or come to another person, and it becomes difficult for them to manage them. Apart from that, I think other things are straightforward. Dr. Hakan's talk was good regarding intraocular foreign bodies. He showed different ways like subretinal, intraocular foreign body, the slightly different techniques, how to take them out. Dr. Geeta Liza talked about traumatic macular holes. Again, there are different techniques which we are using nowadays, and she showed them very nicely.
I had one comment about one of the questions which was raised during the session about sympathetic ophthalmia versus VKH. So I agree. First of all, it's a clinical diagnosis, sympathetic ophthalmia.
सबको भेज दिया invite? Oh.
Okay, so basically, yeah, I do agree that it's a clinical diagnosis. But right now, with the new OCT machines coming up, the swab source has shown certain features which can differentiate the granuloma in sympathetic ophthalmia versus VKH. But right now, the papers which we have published is only looking at 20-30 cases. We don't have a huge amount of data to kind of substantiate that thing. But hopefully, that's probably one of the way we can probably differentiate between sympathetic ophthalmia versus VKH if it is just not on the clinical. So that can be probably a way forward. But right now, it is very difficult to, it's very early days, whether the OCT is the answer for that. So that was something which I wanted to add in that session.
Yeah. But I think the history is the important clue, isn't it?
Yeah.
Especially so in the vision and one eye.
Rupesh, you're there as a uveitis person, and I think I know Dr. McCluskey is there or not. So we're talking about no light perception eyes, and Felipe was talking about cases which are completely irreparable. And we really have to think about at one stage, whatever you do, there's nothing to put together. In such situation, enucleation or evisceration doesn't make any difference.
Yeah. So basically, no. I will say if it's a really very badly traumatized eye with hardly anything left, and you really think it is even going to be difficult to restore the anatomy properly and all, so I think in those cases, probably a good counseling will be helpful. Not that we are afraid of getting sympathetic ophthalmia. We do know that we can treat it, but one has to be really practical also at times. And we really think that your retina is completely prolapsed out. So I think some of those rare cases, you may have to take a call. And those are very rare cases, I'm saying. But most of the cases you can repair, you can put the tissue in place. So one should not give up on the no light perception just because of the risk of sympathetic ophthalmia, because that's quite manageable. And we have good medicines, we have good ways to diagnose sympathetic ophthalmia to manage, not because of the risk, but otherwise. And very good. So I think above all, most important thing which I like about, which I learned from Professor Ferringpoon also, is about lot of thing is about talking to the patient, counseling the patient. So I think that's the most important thing besides everything. If you spend more and more amount of time with them, and probably you will get to know them better and they will understand your approach. So I think besides all the clinical skills. Yep.
Can I also ask you a difficult practical question, especially in certain countries where there's no insurance available? You do the best job possible to put the globe back together, but the patient needs an early second surgery, a vitrectomy, so on and so forth. The patient can't afford it. What should be our ethical, moral, financial implications in terms of not denying the patient what they really deserve just because the patient can't deserve? And how do we address that issue?
I think that's again a very important question, and I am sure everyone would have faced it. So personally, I think I've got Dr. Rekha also here, and we do face, and then she work in a setting where patient really cannot afford. But I think there are defined settings where patient cannot afford, it can be done. So I think here it is the very important key that, let's say I am working in a private hospital, for example, and where the patient has to pay and don't have insurance. It is the time when you have to go out to your senior management, speak to them about certain amount of cases where you really cannot do, the patients cannot pay, no insurance, nothing, no hope. But I think lack of money should be the last thing which should come into the picture. And the board, the senior management board, everyone has to be on the things together. And no matter whatever it is done, I think.
Can I get you?
Yeah, Professor Talma. Professor Talma. Sorry.
I would also think it's a matter of profile. Once again, if you place a retinal detachment the fact is always a very high profile disease. You get suddenly blind, everyone pays for it. But reconstruction of trauma is often very down on the list. In many countries like with us, it doesn't fall under the enforced diseases that everyone has to pay regardless of what it costs. And that brings me to the point that I think often in what we found with ESCRIS very useful is to have sessions on reconstruction after trauma. And that falls under oculoplastics, corneal diseases, all the lenses involved, which is a whole world on its own, artificial irises and posterior segment. So I think it works politically also for making the status of trauma higher. And in that essence, people start to, authorities pay, insurance companies pay better. And I think that's a big project one should do.
Right. Is Dr. Mazzoli still around? I suppose he's not. Dr. Natarajan, could you tell us how you manage in India a patient who can afford the second surgery, third surgery, not a problem, but the uninsured fellow who really needs a second surgery? How do you deal with your financial issues? The patient can't pay it, but the patient needs a medically deserving surgery in a post-trauma setting.
So we actually have a foundation in our hospital, and then I tell the rich patients who are doing well to pay us, and then that's how we manage. Somehow I always told this to the hospital staff: don't send back any patient just because he does not have money. He should not go blind. So we somehow collect the money and do it. And I also do at the cost price, and then try to use something from the previous patient, which we don't use the pack, so that we make the cost come down.
You wanted to say something?
If I may say, what happens with us that we managed to place most of trauma cases in some category that in the private insured cases, they fall under the legal requirements that insurance companies have to pay. So we actually sorted out mostly with that. And in the state sector, these cases are all referred to the university hospitals where obviously they treat it well. So the safety net is quite well. We actually receive a lot from Zimbabwe and neighboring countries, which we managed to slip through the state sector. So these patients are covered well. But it's also because it's regarded as trauma, which in our country is a legalized problem that must be sorted out luckily. And I think that's where everyone should be going.
Question for Professor Graham Holder, electrophysiology, and I think you gave a great talk and people have been wanting to hear about it for a while. Again, how do you address the issue of, you taught us about silicone oil eyes are no good, but eyes with vitreous hemorrhages are no good for electrophysiology. How often have patients been referred to you where it was inappropriate for electrophysiology to answer the questions? And how often do you think that we are not referring enough patients to you for extra information before we go ahead re-operate on these patients?
That's a very difficult question to answer because I don't know what isn't referred. I only know what is referred. Most of the referrals which come through are appropriate because people don't refer. Can you hear?
Yes, Graham, go ahead.
Most people don't refer acutely, and acutely is when it's not appropriate. As Ferenc has said, and my view is you need to deal with the surgery which needs to be done appropriately and quickly and for the benefit of the patient, and then you worry about function afterwards. It's not appropriate to use function at the acute phase. So I think really from that point of view, sorry, I've just realized my video wasn't on. From that point of view, I don't think we get too many wrong referrals because they don't refer acutely. In terms of what should be referred, I think perhaps it goes to a certain extent what we've heard about what's going on in South Africa between the private and the public sector. Public patients want to know what's going to happen. And they don't necessarily, the public patients want to know what's going to happen, but they can't necessarily afford to get the prognostic information that electrophysiology can provide. I don't know the answer to that dilemma. I like the way that Nataraj has got the foundation, which allows public patients to get investigation and treatment if they haven't got the money. But in one of the things, perhaps I shouldn't say this, but I'm going to anyway. In Singapore, I don't think the private patients pay enough, and I think the subsidized patients pay too much. And in some cases, care is compromised because patients' inability to pay.
And keeping a low threshold for referral for electrophysiological services, would you consider that sometimes an abuse of your services, or no, every case is well worth it?
All of the referrals that come through are vetted. So they're vetted for clinical appropriacy, they're vetted for urgency of timing, et cetera, et cetera, et cetera. If I think that something is inappropriate, I will take the time to speak to the clinician and say, why do you want the test? What do you think it's going to give you? Is it going to influence management? Is it going to help the patient? And if they can answer appropriately, then we will do the test.
I would like to make a point, Dr. Ganga, here.
Yes, Rashmi.
Yeah, so what I have observed is that here there are quite a few electrophysiology labs, but they may not be manned by the ophthalmologist or electrophysiologist. And a lot of times a clinician would request for incomplete electrophysiological test. They might sometimes request only for VEP. Now, VEP alone may not give you the complete information without ERG, and you may miss out on something which is going on in retina. So I think that's something which has to be stressed, that if electrophysiological test is being advised, then it's important that a complete set is advised and not just a VEP.
Well, that goes down very much to the person who's vetting the referrals. No test should be done without it being placed in clinical context. And electrophysiology is so specialized that both the technician and the person doing the interpretation must have specialty training. I've seen so many people who've done bad reports or wrong reports, and they have not done an electrophysiology fellowship, they haven't worked in an electrophysiology department, and they think they can just look at an ERG and say it's there or it's not there, and that's not revealing any of the detail that the ERG contains. And it does a disservice.
Thank you. It's time to hand over to the quiz masters, Rupesh, Rashman, Rekha, and Rajiv.
Thank you, Dr. Rekha. Can you switch on your video? Yes. So maybe what we'll do, Dr. Rekha, you can start announcing the winners, and the winners can probably identify themselves and can give a very short kind of introduction about themselves. So maybe
yeah, I have the details of the winners. Dr. Rekha can announce the prizes first. Yeah.
So we have 3 prizes in each category. That is residents and medical students, which were in messy room. And we have books, Orbital Fractures by Dr. Ganga. And all 3 will get these prizes. And for senior residents, fellows, and consultants, we have complimentary registration for APOTS meeting next year, that is 1st to 4th July 2021, Indonesia. So
I'd like to thank Dr. Yunia for the support and all. Thank you, Dr. Yunia and Bali team for providing with this kind of complimentary. Thank you very much.
Thank you very much.
Oh, amazing prizes.
Yeah. So the whole idea of these prizes is to encourage people about the learning of the trauma, and that is where these prizes are kept like that. And thanks to this brilliant idea by Dr. Ganga about this registration, so that they can attend and educate us and educate themselves also about how they are going to work out the trauma, because these are the future stars for the trauma. So that was the whole idea about these prizes. So once they have done, the top resident medical student will get another special prize. But let's complete the introduction by them. Yeah.
Okay.
Dr. Rekha.
Yes.
So shall I announce the winners from the residence group?
Yes.
They've all joined our
maybe consultants
meeting.
Prashant, I think Navneet will. Navneet has got some slides that to help you.
Okay.
Navneet,
project the slide. Make consultant first.
Okay, consultants first then. Third place goes to.
Yeah, just a minute, sir. I'm sharing a slide. Yeah.
Just 1 second, doctor.
Navneet?
Hold, sir. Sharing the slide, sir.
With the sound, just on the share sound also.
Yeah. Yes. Just a minute.
Great. Key
Dear
leaders.
leaders.
Okay. Thank you.
Shall I announce now?
Yes, sir.
Yeah. So the third place in the consultants group, that is the Ronaldo group, goes to Dr. Shahid Alam. Congratulations, Dr. Shahid. Can you just introduce yourself? You're there on the group on the Zoom meeting, right? Dr. Shahid?
I saw him. Yeah, I saw him a short while ago.
Hello, can you hear me?
Yeah.
Yeah, it's Dr. Mohammad Shahid Alam from Shankar Netralaya.
Yeah, we would like to see your face also. Would you switch on your video? Yeah, good.
And you are a consultant in which subspecialty? Your consultant retina, oculoplasty?
Oculoplasty.
Okay. There are many oculoplasty questions there, therefore. Right?
No, not actually.
Stop
And
the price if you want.
can my name in the certificate be corrected? It's actually Dr. MD.
We'll take care of that side. Doctor, don't worry about that, Dr. Side. We can take care of it.
Okay.
Thank you. Congratulations.
Congratulations, Shahid.
Yeah.
Okay.
And the second place goes to Dr. Anjali Khairnar. Dr. Anjali is here. Please introduce yourself. Congratulations. Dr. Anjali?
Dr. Anjali, can you switch on your video and say quickly about yourself?
Is there? Dr. Anjali?
Yes, sir.
Yeah.
Hello.
Yeah.
Can you hear me?
Yes.
Yeah. Sir, thanks a lot for this opportunity. First of all, it was a very nice experience after a long time. And myself, Dr. Anjali Khairnar, I am working as assistant professor in a medical college in Dhule, which is a place in Maharashtra. And I have done my fellowship in glaucoma from Arvind Eye Hospital. And yeah, right now I'm working as a consultant, assistant professor, basically.
Fantastic.
And thank you very much for this
Fantastic.
experience.
That's very nice that the people are from Dhule and all the regions of interior of Maharashtra, people are participating. So that's very nice. So that's one of my favorite place, Dhule. Very good.
Thank you.
Okay, and coming to the winner here, next. Winner of the Ronaldo group, Dr. Jis Mary Santosh. You are there on the group. Congratulations. Please introduce yourself.
Hi, everyone. I'm Dr. Jismeri Santosh. I finished my residency from Regional Institute of Ophthalmology, Chennai, 2 years back. I'm not working anywhere currently. And I'm just planning to do my fellowship. I completed 2 years back. So, yeah. So I'm planning to do my fellowship soon.
Go
like to reveal your hometown.
Sorry, sir?
You like to reveal your hometown?
My hometown is Kerala, but I've been in Chennai for almost nearly 20 years.
Kerala is not a town.
Huh?
Okay, Kottayam from Kerala.
She's a student of Ramchandra Medical College, and her mother is a faculty in Ramchandra Medical, right?
Okay.
Yeah. Her sister was my student at Giridhar.
So fantastic. Once again, congratulations to all three winners in this category. And we would like to see you in Bali. And definitely we'll welcome you and we'll like to hear more, maybe with your free paper or some other talk on the Bali meeting. Right, Dr. Ganga?
Mukesh, I think this was fixed because the president of the society is actually from RIO-GOH.
Ah.
You may have leaked the question.
And the quiz master from Shankar Netralaya.
Chair scientific committee is from RIO-GOH.
Guess what? Her sister is placed 5th.
Congratulations. Very, very happy and proud.
Good. Fantastic. Very nice. Okay, let's move on to the another category, but we'd like all three of you to be there in Bali with us, and hopefully the things have gone back to normal.
A photograph, please. Yeah.
Yeah. Next.
Done. Photograph done. Yeah.
Okay, then we'll move to the residence group, the Messi group. The third place goes to Dr. Are you ready?
Yep.
Dr. Vrinda K. Ramanan. Dr. Vrinda, are you there on the group? Congratulations. Please introduce yourself.
Yes, hello sir. Thank you all. I'm Dr. Vrinda K. Ramanan from Amrita Institute of Medical Science, Cochin, Kerala.
Wow.
I'm final year PG resident, sir.
So you practice in Cochin only?
Yes.
Yes,
so
sir.
we have two people from Kerala.
Great. Congratulations, Brinda. Very good. And,
Thank you, sir.
Definitely, and I hope you will enjoy reading the book by
Yes.
Dr. Ganga. It's very illustrative, very nice. Okay.
Thank you so much, sir.
Agarwal has written a chapter on it on ocular trauma.
That's why I said you will enjoy reading that chapter. I was trying to bring you to that point. Okay, Ken.
Okay. Congrats there again, Brinda. So the second place goes to Dr. Mary Stephen. Dr. Mary, you are here?
Yes, sir. Sir, good evening, sir. Thank you for the opportunity. I'm Dr. Mary Stephen from UNICEF from Japan, sir, Pondicherry. I'm finally here, sir.
Voices.
Voice is breaking.
Jipper Pondicherry. He's a final year at Jipper Pondicherry.
Jipper Pondicherry, yeah.
Once again, very heartiest congratulations, Stephen. And we hope to kind of listen more from you at different platforms for your free papers and other trauma work. So hopefully you can contribute more in this field. Thank you.
And finally, the winner of the quiz, it is none other than Dr. Shreyas Damorikar.
Fantastic.
Dr. Shreyas, please
good evening, sir.
introduce yourself. Yeah, good evening.
Myself, Dr. Shreyas Damorikar. I'm a final year resident from NKP Institute of Medical, NKP Salve Institute, it's in Nagpur, Maharashtra.
Right. That again is match fixed by the president of the society.
Maharashtra, Jai Maharashtra.
Chief quiz master from Nagpur.
Nagpur, and I'm a Maharashtrian. Welcome. Yes, congratulations.
Thank you, sir.
You don't, even though I don't have anything to do, but we are proud. Jai Maharashtra.
Thank you, sir.
I invite all the three winners of the books to become oculoplastic surgeons.
No,
Surely, sir.
I will invite the last winner to another offer. The first, the topper. Can I share my screen? Can you see my screen?
I need us to stop sharing. Yeah, we can see.
Okay. So this is the surprise prize for the winner, so that he does not become an oculoplastic surgeon, he become an ocular trauma surgeon. So Shreyas, this is for you. So besides oculoplasty, if you can take up ocular trauma thing, so this is.
Yes, sir. Surely, sir. Thank you so much.
Correction. I know he's written ocular trauma. You, me, and Gangadhar are going to write ophthalmic trauma.
Ophthalmic trauma. That's what you're doing.
Every slide has to change. Put ocular one cross and then put ophthalmic. But I also remember like that. So every slide of Ferenc Kuhn or the Dr. Masulani's or everybody had ocular. So I think damage ophthalmic. I think what damage DOC is what damage ophthalmic. So at least he had ophthalmic. The rest of them had ocular.
Absolutely.
Perfect. So once again, congratulations to all the winners and the residents. And we really
for a joint photograph, please.
Thank you.
Done, sir. Done.
Photograph like this, sir.
Yeah.
Thumbs up. Everybody.
Everyone, please switch on their videos.
So Amer and Annette is very. Caroline is there.
Just doing it.
Yes. And everybody should smile also.
Okay.
I smile, sir.
Family has imbibed excellence, dedication.
Done, doctor. Done. Any more? Yeah, thank you.
Thank you.
Over from the quiz team back to Dr. Ganga and the team. So thank you once again, the quiz masters, Dr. Rekha, Dr. Ashok.
Rekha and Dr. Rashmi.
Thanks a lot for all.
Thank you very much.
Wonderful. I think because of quiz, I think everybody will come to do ophthalmic trauma. Rajiv and
Thank my team, Rupesh, then Rashmin, Prashok, and Rajiv. Everybody worked hard for the success of this.
Patient care and management.
Personally, thank you all for your hard work and all the communications to and fro and making this happen. Thank you.
Thank you, Dr. Natarajan, for taking this quiz in this forum.
No, I think thank Rupesh and Ganga. And Ganga said not to repeat his name, but I think mainly I have to tell. So it's good. I mean, all of it, it's a teamwork, and I'm happy to lead the team. That's why I'm happy that you are allowing me to lead. Thank you very much. Yes, Ganga.
Can I share?
Yes. So are you sharing anything else, Ganga?
No, that's it. I'm just going to give the concluding remarks. Is that okay?
Ganga, I thought you were sharing some shares of the company.
I have to join hands with Ferenc Kuhn, first put together this ocular and adnexal trauma in one book, and we'll make it happen. That will be the of APOTS and ISOT. May I?
Yeah, sure.
Thank you, sir. Thank you so much. That was indeed very reassuring.
So I just wanted to wrap up saying that we had a wonderful 2-day program. Believe it or not, it supposed started off with a 90-minute program, went on 4.5 to 5 hours per day. A beautiful address to start with, started by beautiful coordination with Dr. Agarwal. Great section chairs, speakers, keynote lecturers, and we heard that all yesterday. Once again, to complement how COVID-19 has actually increased knowledge sharing. You can see in the flag map over here how many countries have contributed and come together. So it is not just an Asia-Pacific Society conference, but it's actually a global conference with countries from all around the world, North America, South America, Africa, and Asia-Pacific as well. I'd like to thank Professor Caroline Chi, Akshay, and Kendrick for leading the show today, as did Dr. Natarajan and Dr. Rupesh yesterday. And today's show was, one of the stars was the Allied Health Program. This is not often that they participate in pure ophthalmic and ophthalmic trauma meetings. And they taught us literally how we don't give up just because somebody's got irregular astigmatism, corneal scarring, autorefractor doesn't work. They really taught us how we can restore them to normalcy as the best that they can. And even when the eye is blind, how an ocularis can replace a prosthesis. So these kids and adults can go back to schools and societies as normal looking people, normal feeling people. Retina session was fantastic. And Dr. Peter McCluskey wrapped up a beautiful retina session saying that you should still be worried about sympathetic ophthalmia, but not as much as before, because if you're able to accurately diagnose it in the early stages and proactively manage it and conquer it, the idea is prevention. That's where the skill of the vitreoretinal Bayan, Geeta Lisa Hussain, and Wai Ching Lam showed us that the skill can actually prevent a lot of this sympathetic ophthalmia. And finally, we had a beautiful section on global perspectives. And I'm very happy now we are able to bring together not just APOTS alone, but APOTS along with the International Society of Ocular Trauma, the American Society of Ophthalmic Trauma. I'm glad they took the word ophthalmic trauma, the APTO, which is a South American trauma. And by joining hands with the African continent, with Dr. Talma, who's joined us today, we are hopefully forming first a consortium, an idea of minds together, so that we bring our trauma work together and eventually form a special interest group. And finally, an African trauma, ophthalmic trauma society. And the idea is not just to form a society with leaders, but make sure that the knowledge trickles down to the basics, so the patient gets the best treatment the very first time. And thanks also to Dr. Rekha, Rajiv, Prabhashobh, Rashmin, and Rupesh for putting this wonderful quiz program together, and the participants who took together as well. I invite all the participants to go to APOTS webpage, log into the APOTS webpage where you can provide a feedback. There's a nice feedback designed by Akshay and Dr. Rupesh. Once you provide the feedback, you will be getting your automatically generated certificate if you're interested in the certificate of attendance for this conference. And we are also going to be showcasing the APOTS clips, where as a good example of a good clips here, a good learning point, one simple tip or two simple tips for trauma management, we're going to be making available a template. Prashobh will be sending it to you all, where I want every member, every participant, every speaker, every chair contribute important salient trauma-related pearls that eventually will go into the APOTS database and APOTS website. I'd like to thank Micro Labs and Microvision headed by Ashok Kumar, Navneet, the energy behind it, Amit, Arshad, and Mana, who really made this beautiful educational opportunity on a global platform. Personally, thank you very much. I really, really want to thank them. And none of this will be possible without a team. We're talking about a multidisciplinary approach to trauma management. And I think this is a team we've been putting our minds together, hearts together, communications together, late night webinars, Zoom meetings to make this happen. If you've seen something work very well, it's hats off to every single member, not just on the slide, but every single member of our APOTS membership who have contributed in various ways. Time now to welcome you all to the July meeting by UNIA, Dr. Professor Chayono and Dr. Siddiq from Jakarta and Chipto, who have taken the initiative to move the meeting, which was supposed to be held this weekend in Bali, to next year. And you've seen the winners being announced. And I invite all of you to come and attend in big numbers to the physical meeting going to be in July. And we are not just looking forward to 2021, but we're looking forward to 2022, Langkawi, Malaysia, where Dr. Tengku Ain was going to be organizing the meeting in 2022. So thank you very much. And I'd invite everybody else to share a few words. Thank you.
Thank you, Ganga, for a wonderful, opportunity. And I think it's really, I'm happy. I was when I went through all the mails from 2010, I'm glad many of the mails are with me. I'm audible, Ganga?
Some background noise. Can somebody mute that other microphone?
I'll do that. I just put the Shankar Netralaya Foundation Day going on. Okay, I muted it. Okay, so sorry. No, I said I'm glad that I'm heading Asia Pacific Ophthalmic Trauma at the right time, because thanks for the opportunity by all of you, specifically Carolyn Chi, Professor Azad and Rupesh and Dr. Gangadhar. And I still remember every meeting we had from 2010, and we never had a room. So every time we were sitting in some corridor, some restaurant, I still remember the APO meeting in Sydney. We were in the road, not in the road, whatever, they are part of the side of the riverside. And then even in earliest, I think, WOC we had in Abu Dhabi. And I'm happy that even 2012, we had a major meeting with the Huayan. We have the beautiful photograph with me and Carolyn solely representing APOTS. And then he announced it and put it in every LED screen and every slide there for 2 days. And everything was in Chinese, of course, except the APOTS was in English. So it was great. I mean, I'm happy APOTS has become really global. And we are very happy with everybody interested. And that's my dream. Every ophthalmologist should know that every ophthalmologist will encounter an ophthalmic trauma patient, right from just a lit tear or a corneal foreign body to something serious or a polytrauma in a major hospital. So I think everybody will encounter. So I think everybody should, even if they don't practice, at least they should know what can be done. And I think there's so much of advances taking place in management. Don't give up. Don't say just remove the eye. And I think if you convey that as a take-home message, anything can be repaired. But again, whether the patient will see, I think it depends on how much hard work we have done and depending on the injury. And with all this, and I think people are asking, oh, can you remove the eye and put an artificial eye? And I think so many questions public have. But I'm glad these sort of webinars are there in YouTube and Facebook Live, where I think people will know how much hard all doctors are doing to learn their skills. So thanks to each and everyone, specifically Microvision team. I think as Rupesh started the meeting today, and Ganga said, and today with the slide, but specifically Ashok heading the team with the entire Microvision team. I think we never had an experience like this with any company. I work also with several companies, and I think they do it. But I think here they actually directly command us also. Even yesterday, I finished in time, but they told, even a presidential address was told, you have 1 minute to go. So I'm glad they did that. And I think that's what I'm allowed to do. And I think everybody has to follow the rule, whether it's me or even Professor Talma or Dr. Ferenc Spoon. And I think the only thing, the timing they did for Ferenc Spoon, they said 11. So I'm glad. I think with this, as I said, I mean, even though it was like almost 10 hours sitting like this and several working hours we have done, I think I'm not bored. And I never felt, oh God, when it'll get over. But I'm glad. This stimulates me. I was about to tell, but I don't know whether I'm hesitating, because if I announce, Rupesh will jump and Ganga will jump. I hope Kendrick is not here. I don't know. And I thought we should do monthly webinar.
No. So many younger people on board.
You can definitely do that thing. And that's a great. But you forget to mention one of the restaurants which we sat in Busan. You remember the name of that restaurant?
It's an Indian restaurant. That photograph yesterday I put
the restaurant name was Ganga Restaurant.
Yes.
Yeah.
Photograph of that.
The Ganga Restaurant, and that was the game changer meeting where we had that meeting with Dr. Ganga in Ganga Restaurant.
In 2012, that was Busan.
Yeah, 2012 in Busan.
And Carolyn was there, you were there. And that photograph yesterday Carolyn sent me, and I also found out we have put that. So I think all that should go to the website. And I think whoever can put the caption, it'll be nice for all the new people who have just joined to see the history of APOTS. More than history, I think it's a difficult job to put a society together and make it work with IROSs, now with the APO. I hope next Saturday, the APO will finally announce. I saw the mail in 2015 when we applied. They made an associate member. Thanks to the most hard work done by Rupesh and Dr. Carolyn Chi for putting APOTS as a regular member. I think we deserve to, and we are also thanks to you for the regular ICO member. So we are actually an international body, a supranational body, and member of both ICO and many societies involved. Thank you.
Thank you. Thank you, Prof.
Words?
Who?
Caroline, would you like to say a few words?
Unmute.
Yes, I think it's been really. Sorry. I think it's been a really fantastic. And I think the whole breadth.
Switch off one of the devices.
Of one of the devices.
There are two. Just switch off one of that and just use one.
Yes.
Hold on. Another one, phone you can switch off. Phone or the iPad.
Hang on
you
a
can
minute.
leave that. You leave from that device. One of the device. The second.
Doctor, switch off the iPad and use the mobile for
No, I'm
speaking.
trying to. Yes.
Just leave from that. That particular device, just leave that.
Ashok, can you mute one of the devices? You can do that.
Ma'am has to mute the
Okay,
iPad.
how's it now?
Now it's better.
Right. I mean, I think the breadth of topics that we've covered, it's really a whole masterclass of it. And if a resident had sat through it, they would really have learned 80% of trauma. So I think it's been a remarkable experience. And I think, this idea of teaching through distance teaching like this, I think it's absolutely doable. We can put up how do you suture a cornea, how do you suture a lid, just basically a whole platform of how do you do primary repairs. And I think if anything, the very few things that COVID have been good for is that it's forced us into this platform, and we've now realized what the potential that we can use in it. So I think thanks to Ganga and Rupesh, who have worked so hard, and our sponsors and everyone who's made this happen. Thank you very much.
Rupesh, finally you.
No, thank you very much. Most important thanks to Professor Natarajan. He has been saying many things, but I think is the single person who has just given us license to go for anything, never kind of stops us and just inspire us. And a lot of times it has happened, I was in stress for different reasons, and he will be the first person to call me, and he will speak to me he may be very busy, but he'll speak to me for hours together. So thanks, Dr. Natarajan, for standing besides. And then definitely Dr. Ganga has been always there. And every single thing he will message me if he can help me with anything. So I think great effort. And Professor Carolyn Chi has been a real good mentor all along. So I think we have a good team with us, led by Natarajan sir, and of course in the research field, Annette has been helping a lot, and we are doing great work. And then of course Dr. Rekha from Nagpur. Overall, the work has been going on very, very well. But I think what Dr. Unia and Geeta have started is setting up a trauma center in February, which we missed. So I think that's the way to go forward, and probably we need to do more and more. So I think my emphasis again, as Professor Jain Dalma also said, we need to set up some more training program, something more. So I think we need to do as a society more concrete program moving forward, setting up more trauma units, and probably as Dr. Natarajan said, so without hesitation, I accept your monthly webinar option, but we will structure it to come up with a virtual trauma fellowship. If you can come up with APOTS, ISOT, OTSI virtual trauma fellowship, we can structure it, we can brainstorm, and then come up with a good plan with a proper speaker and with a proper outcome. So then I'm quite all right with that, and we can definitely take it forward. Thank you very much once again. And of course, Ashok and Navneet, many thanks for support.
Thank you, Doctor.
For the Ophthalmic Trauma
Yes,
in Jakarta, APOTS I represented, and you and Ganga could not come because of the travel restriction.
COVID, yeah.
That's the first time we encountered the masks for few people,
Yes.
and then temperature check for the corona. Even then, I remember Geeta called me 2 days before and said, "Don't worry, everything is great." I said, "No, I'm coming." And luckily, coming from India, they didn't put me in the quarantine. But one group, I don't know from which place they came, they were all sent to a separate counter, and they said, "You have to do this." And I had to come back for all India. But it was a great thing.
First year in many years, I have not traveled anywhere outside. This year, 2020, not traveled anywhere.
Yes. But great. 3 cheers to APOTS.
Three cheers to APOTS, 3 cheers to Microvision, Microlabs for the team effort. Dr. Talma, can I have 1 minute of your words before we close up?
Yes. Yeah, once again, thank you very much. I think you managed to convert a COVID crisis into a wonderful training opportunity, which we probably wouldn't have had. And I must say thank you very much to everyone, the organizers, Ganga, Natricha, Agaval, every one of you. Thank you so much for doing it all. And you've really stimulated me and on my side to start doing something about our sub-society in Africa. Thank you very much.
Let's shake hands on screen. New partnership. Nati?
We do it.
Let's shake hands online for a new project.
Yeah. Thank you very much.
Thank you very much. All have a good rest of the weekend, and we'll be in touch. Thank you.
Yes, thank you very much.
Thanks, everybody.
Navneet and the entire team.
Thanks, gang. Brilliant.
Good night.
Good night, everybody.